Good evening, Dr. Varsha.
Hi, Manisha.
Pratik sir.
3, 2, 1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I invite you all for this Perfection Series webinar on topic Male Infertility Unraveled. As in every CME, we start with this lightning ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now it's my privilege to introduce the convener of this series, Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is also professor at Ellen Medical College, Bhopal. She is managing committee member, ISAR. She is also West Zone Coordinator, Medical Resource Committee, FOXY. And also she is convener of ISAR Perfection Series and convener of FOXY Symbiosis Series. Now I will hand over the session to Dr. Monica Singh.
Thank you, Dr. Vishal, and thank you, Intas, for giving us this platform to conduct our academic series. ISAR Perfection started in March 2023 after Bhopal ISAR, where we, Dr. Nandita Palshetkar, Dr. Sunita Tendulwadkar, and myself decided that let us do some academic series where ISAR is involved in various themes of topics which can benefit all ISAR members as well as everyone who's practicing ART in India and abroad. So this series started in March 23, and today, fortunately, we are on the 11th episode on male infertility unraveled. And I'm delighted to welcome all of you here, all our faculties, all our dignitaries, and definitely I would like to thank ISAR President, Dr. Amit Patki, our patron, Dr. Nandita Palshetkar, immediate past President, Honorary Secretary General, Dr. Asha Bakshi Madam, Chairman Embryology, Dr. Charudat Joshi, my co-convener, Dr. Randhir Singh, and our coordinators of Perfection Series, Dr. Fessy Louis and Dr. Pratik Tambe. So without further ado, I would like to, I think Dr. Nandita, if she has joined, it's okay. Otherwise, we'll just thank Madam and proceed. Manisha, you will just give me a signal if Madam or anyone, joins.
Yeah.
Yeah. So we definitely would totally indebted to Dr. Nandita Palshetkar because she had just returned. It was just a few months, weeks after ISAR, and Madam was just on a flight. She was on the airport when she gave us a, thumbs up for ISAR Perfection, and so it started. She is an exemplary leader in India. She is one of the, the force behind ISAR because of whom ISAR has grown, like the way it is growing. And next, I would like to welcome and our President ISAR, Dr. Amit Patki. And Dr. Amit Patki has recently taken over as President of ISAR. He's a very dynamic leader who is the country representative of Aspire, Governing Council member of ICOG, definitely a very dynamic President of ISAR who, enthralled all of us with his great speech in ISAR Bhubaneswar recently. General Secretary MSR, Chair West Zone RCOG, and President MOGS. Besides that, Sir is a keen academician. We thank Dr. Amit Patki for continuing ISAR Perfection. And he has even told us to go ahead with the program throughout the year. So we are thoroughly indebted to Dr. Amit. Next, I would like to welcome Dr. Asha Bakshi. I just talked to her a couple of hours back, so I think she will join us anytime now. Madam is Honorary Secretary General ISAR, and she has held various important posts in RCOG, IAGE. She is the founder of MP ISAR. She is very active in PCPNDT Committee of Indore, because of which we are all practicing, conveniently doing her obstetric practice without any fear. She has held several important conferences, and Indore has become a sort of, hub for all these big conferences she has done, including ISAR twice, AICOG, and recently, the very recent conference, New Age OG Con 2023 in Indore. She has many firsts to her credit. We thank you, ma'am, for being a great leader and always supporting us. Dr. Charudha Joshi is also a big leader in ISAR right now, and he has taken over as chairperson embryology ISAR, chairman embryology ISAR. Sir is postgraduate in life sciences. You can see his degrees, MSc, PhD, and he has opened a Genes India ART Bank in Indore, which is a fully dedicated center where we can do our ART procedures conveniently through protocol and without any fear. Sir has held many important posts in all these organizations like ISAR, IFS, and ACE. We welcome Dr. Charudha Joshi. I would like to thank my co-convener, Dr. Randhir Singh, who is Managing Committee member ISAR and has organized a very successful 27th annual ISAR in February 23 in Bhopal. Next, I'd like to introduce our chief guest. Dr. Fesilu is busy till 5:30 p.m. Dr. Manisha?
Yes, ma'am.
As soon as he joins, we will introduce him. He is coordinator for Perfection, and Dr. Pratik is there with us. He is our coordinator of Perfection series, a very good friend, a very good, academician. And as you can see from his CV, he has held all important posts of ICOG. He has recently joined as governing council member, the Indian College of Reproductive Medicine, which was launched by Dr. Nandita Palshetkar in ISAR Bhubaneswar. He has held important posts in MOGS, MSR, and is at present also the managing committee member of Indian Society of Assisted Reproduction. He has held the post of past chairperson FOXY Endocrinology Committee and past chairperson AMOGS Endocrinology Committee, and he's like the Rahul Dravid of ART and ISAR in India. Like whenever you need something or you are at a loss, and you want some suggestion, some opinion, at least for me, he's always there. So thank you, Dr. Pratik, for joining us today. Welcome, Dr. P.K. Shah, sir. Our chief guest has joined, and I'm delighted to, before introducing my chief guest, Dr. Pratik, would you like to speak something about Perfection and what you feel about?
I'll just take 30 seconds to congratulate Monica and Randhir for conceiving of this brilliant series. I've been there since the inception, I think, since the very first or second program, which we sort of brainstormed together. Thanks very much to Dr. Nandita Palshetkar, who was then the president and who gave us permission to go ahead. Congratulations to both of you for bringing such excellent academics regularly on this online platform for all of us who cannot attend physical conferences. Wishing you all the very best always.
Thank you, Dr. Pratik. And now I'm delighted to welcome our chief guest amongst us, Dr. P.K. Shah. Dr. P.K. Shah needs no introduction. He has mentored and taught thousands of students in these two great medical colleges, LTM Medical College, Sion Mumbai, and KEM Mumbai. He has held all the important posts in all the big organizations of obstetricians and gynecologists, past President FOXY, IAG, IFUMB, MOGS, and AFTT. Also the past Dean of Indian College of Medical Ultrasound, and the past chairman of Imaging Science Committee of FOXY. His committee was also awarded the Best Committee Award. He is a dedicated academician, very disciplined. In every webinar, he is there right from beginning to end. I have seen him from the local AMOGS conference to national conferences. So we are so honored to have you here. And we would be blessed if you could, impart some topic and your vision of ART to all of us.
Yeah, thank you, Monica. First of all, thank you very much, ISAR, Dr. Amit Patki, Dr. Nandita, Dr. Asha Bakshi, and all the office bearers of ISAR for having me here as chief guest. And also I would like to thank Dr. Randhir Singh and Dr. Monica, along with Dr. Tracy Lewis and Dr. Pratik for being here. It's so nice to have Dr. Hema. I don't know whether she's joining or not, but the guests of honor, Dr. Ritu Khanna and Dr. Neeraj Jadhav, whom I know and for whom I have joined many webinars in the past. And also I would like to appreciate the work done by special guest, Dr. Apurva Kumar. And he is a fantastic guy, and I'm sure he'll be doing a great job in future for Foxy and various organizations. Coming to the topic of this particular webinar, male infertility unraveled, I think it's a less talked about topic amongst obstetricians and gynecologists. So I'm very happy that ISAR has taken up this topic, and especially the Singh family for having this topic, because gynecologists feel that when it comes to infertility, they have to only examine the lady, and majority of causes of infertility, the major issue, male infertility, is left out. So it's so nice to see that some of the topics which are covered are so important, like you have a male infertility for gynecologists, what is new? Again, a very interesting topic I'll be listening to. Medical management of infertility and fertility in aging males. Plus, I think Dr. Venugopal is going to conduct a panel discussion on case scenario. So nice to hear Dr. Sunil Jandal, Dr. Nagori, and Dr. Tanya Bakshi today. So thank you very much and wish you all the very best for all your future events. This is the first time I have joined your program, and I hope in future I'll remain with you. Thank you very much for having me today here. Thanks a lot and all the best.
Thank you so much.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. We are really honored to, have you amongst us and bless us with your, words of wisdom. And after introducing our chief guest, Dr. Hema Divakar, we will like to welcome Dr. Asha Bakshi, who has just joined. Welcome, Hema ma'am. We are honored to have you amongst us. I had the privilege of interacting with Hema ma'am in JIPMER just recently, but she was there for such a short while that I missed, having some good conversation with her. But always we have admired her, Hema ma'am. She has visited Bhopal, I think, ma'am, twice. Yes. And every time she's such a positive and dynamic personality. Madam is working in a very interesting center called the Asian Research and Training Institute for Skill Transfer, which makes up a part of her hospital and shows how dedicated she is towards ART and women's health and towards teaching. Besides that, she has, she is the recipient of FIGO Women's Achievers Award, Global Asian of the Year Award, CME Excellence Award for Artist, Next Brands Award for Artist for Her, and CSR Times Award. Madam has been the President Foxy, Dean KCOG, Vice President Karnataka AHPI, Chair of Well Women Healthcare at FIGO, President Dipsy, ex-Vice Chair for FIGO PLCT Committee, past President of Foxy 2013. And she is a great, advocate for Manyata project, an opinion leader, a great influencer, very close to social and legal issues relating to women's health. And when she talks, everybody listens. So, Hema ma'am, we would be very honored if you could give some insights from your vision of ART, vision for this country, vision for the women of the country.
Namaskar. My first shout out is to Monica, oh my darling. How can you have such an imperfect chief guest for the Perfection series? Okay, that is my first comment, because many people in the country know I'm into this, that, and the other, but I'm not a super expert at the topic that you're going to deliberate today. The least I was waiting for is for Dr. PK Shah to join, because PK, though it looks like PK, but his name is so beautiful, Paramanand. It's always a pleasure, PK, to be full of joy when you're around. He's been my teacher too. And all the other office bearers and other guests of honor who would probably more appropriately, Ritu and Neeraj, who would throw more light on the specifics of the topic. But as far as my mind runs back and forth, this topic of male fertility issues is both advancing scientifically and socially. Scientific advances, besides the routine semen analysis, which we used to always do, there are so many nuances in the requests for many more tests, inclusive of the semen microbiome, this, that, and the other. And there have always been standards setting and resetting as to what makes up a normal kind of a report. But socially, as Dr. PK Shah said, we've come a long way in the last 4 decades. A long, long way, because but I do remember very, very long back when the women came and sat in front of me and with a small face and said, I'm the 6th wife of this man. I said, oh, what on earth is happening? Why is your husband marrying for the 6th time? And it was all about her huge pile of papers of the fertility workup that she had undergone. I said, okay, but where is your husband's test? Where's the semen analysis? Nowhere in the picture. And somehow we caught hold of her mother-in-law and a religious leader whom we knew as a common contact, and somehow brainwashed that man to get his basic test of semen analysis done to discover that he's azoospermic. But the confidentiality that we had to maintain around the donor sample, etc., was a huge social, stigma and a barrier. So there goes the story of how we have come a long way, when now the elite hi-fi patients always wanting to be with their partners or their wives and asking many more questions than she asks, also about her and about themselves, and how much they are also aware of what's going on in this space, and most willing, or more than ever willing, to subject themselves as an equal partner and equal standing for many of the investigations that we need to do for the couple. So the scenarios in metros is definitely changing, but still, with the gender equity issues and the social justice which Monica just talked about, there's still a long way to go, because we do a lot of video consultations, and some of the remote places in India, the women do not have their own mobiles. We have to wait for the husband to come and lend the mobile to her for the short conversation, and she can only ask what she's allowed to ask, etc. So there is different levels of the social strata which tackles this issue in a mix of a chaotic perfection, imperfection kind of a manner. So this title of this whole series, striving towards excellence, striving towards perfection, is the duty of all of us as healthcare providers. Otherwise, we'll be failing not only our girls and women, but the community at large. So, when you see the ad of Raymond, what makes a complete man? Wear a Raymond suit, like that. It is what makes a perfect man. Maybe today's discussions will tell us, additional points as to what we should pay attention to and how best to use our wisdom to make the outcomes better than ever before. So once again, thanks to the whole ISAR team and the leaders of this series, the things, as how we have been told, it's an absolute pleasure to just be there for nothing, only for Monica. Thank you so much. Namaste.
Thank you so much, ma'am.
Thank you, ma'am. Thank you, Hema, ma'am. Actually, just I was reading your CV. You are the Vice President of Karnataka AHPI, Association of Health. But I mean, MP also, I was the person behind started this association, ma'am. We will be taking your help for the national level, because AHPI is in direct contact with the health minister, very well. So
Absolutely.
we'll be giving suggestions. And as the infertility is a WHO notified, ma'am, so we are not going to leave you. We'll catch you for the national level also. Thank you,
I'm
ma'am.
always available. Now I'm the president for Karnataka, and also recently in the conclave that we had in Ahmedabad, I have been now given charge of the skill transfer, AHPI Skill Gurukul. That's the big banner under which the skilling programs with the Health Sector Skill Council and the ministry are going to be operating. So yes, if not anything else, we should definitely provide, AHPI is Association of Healthcare Providers. It is our vision and mission to provide skilled providers across all cadres who are going to change the healthcare ecosystem. So this is a very good piece of information that we have shared between ourselves
Yeah.
today.
Actually,
And
madam, we
we will
missed it.
move
Yeah.
together
Actually,
and
we missed.
stronger.
Yeah. Sure. Madam, we actually missed that. Same date was the Isar Bhuneshwar.
Yeah,
So Dr. Girdhar Gyani was very close to me, so we could not go there, ma'am. Thanks, ma'am. Thanks.
Thank you so much. Thank you.
Thank you. Thank you,
Asha madam
Hema.
is
And despite your statement of imperfection, madam, there is nothing close to imperfection in you. You are the epitome of, magnanimity and so warm-hearted, so out in your emotions for everyone. Thank you, Hema ma'am. And I always
Thank
feel
you.
that we had a few, our coordinators and myself, we were discussing how much time we should spend in intros. But if we don't have introductions, we don't interact like this, the whole webinar loses its significance. I think this is, besides the academics, the most important part of the webinar is interacting, because even in a physical conference, I'll never be able to talk so freely to Hema ma'am, to Nagori sir, to PK Shah sir, as we can do face to face now. So I feel introductions and talking your heart out is a very, very important part of every webinar. So thank you, Hema ma'am.
Thank
And
you.
Monica, just I'll take a few seconds. With this discussion, ma'am, we raise the problems and we can handle this thing to the government. Recently, in the surrogacy, how we won it. The
Yes.
government is not ready. Sir, PK Shah sir, when Supreme Court had given many decisions, they modified. So similarly, ma'am, as health provider of India, actually IMA is the largest body, but IMA is basically a physician, not the hospital. So we are the providers. So we have got a different problem. So Monica, by this introduction and all, we come to know and the solution. We all members need a solution also. Thank you.
Absolutely. Thank you. Namaste.
Before introducing our guests of honor, I would like to invite Dr. Asha Bakshi. Dr. Asha Anil Bakshi is the star of ISAR who belongs to Madhya Pradesh. And Madam has done all of us proud with her achievements, with her, dynamism. She is a true leader for all who are associated with her in the state. Madam, we have introduced you as Secretary General of ISAR, a great teacher, a great leader, who has done some, super successful conferences in the city of Indore. And everyone in MP counts her as their own. Madam, it would be very kind of you if you could speak a few words for us, all of us.
Thank you, Monica, for the kind words. First of all, I would like to really thank you and Randeep for starting this series. And as I know that this is the 11th episode of the series, and you have been doing this since last whole year, and it was going so well that Dr. Patki decided that we continued it this year also. And the topic you have selected is really good. But before that, I would say that the chief guests like Dr. Hema, Dr. PK Shah, they are really stars, and so nice to have star-studded webinar today. And again, I know very well Neeraj and Apurv, and they are all very good. And I've worked with them. They were in my committee for sexual committee, so I know how hard they have worked. And the topics selected are very good, and the speakers are again very, very, very good. So I'm sure this is going to be a very, very good discussion. And this year, the theme actually of ISAR, which has been selected by Dr. Amit Patki, is male infertility. So I'm glad that the first webinar you picked has been on the theme of ISAR, and that's really good. And whenever a couple enters your clinic, you just start looking at the wife, and you hardly even bother to look at the husband. और वो husband बेचारा कब से देखता रहता है कि कोई मेरी तरफ भी तो देखे, मुझसे भी बात करे, मगर वो तो बेचारा हमेशा ही neglected रहता है. फटाफट we are all the time talking about the lady, working her up, and okay, just semen analysis, and the man has to give sperms, and that is it. But the time has taught us that it is really very important to talk to husband, to look at the husband. You may just pick up obesity, you may just pick up hypothyroidism, you may pick up many metabolic problems that the husband has. Anemia, even simple anemia, if that is treated in time, can improve male infertility. So there are so many things you can pick up by looking at the husband, talking to him, checking what is his profession. And these days, so many treatments are available for male infertility. I still remember, and I'm sure you all have read in the newspapers, a man with azoospermia has committed suicide. But today we know that azoospermia is not a bad thing. And sometimes in PISA and TISA, you get such good sperms that the fertility results are very good. And even in those cases where in TISA you didn't get sperms, you have another thing which is known as micro TISA-HC. And that also gives you very good results. So male infertility is not a hope. Rather, you should be happy that, oh, it is there, I can treat it and we can get the results. So I think it's very important that we give equal importance to men as women. And today we have got lots of learning points from people like Dr. Nagori, Dr. Jindal, Dr. Tania, and the panel discussion by Venu Gopal. Venu Gopal is also an expert. So I'm sure we'll all learn a lot. And please continue with your webinar so that we have more time for the scientific content. But wonderful, and keep doing the good work. Thanks.
Thank you.
Thank you, Bakshi ma'am. Thank you.
Thank you so much. That was the whole aim. We have handpicked our speakers. Dr. Sunil Jindal is a name who is well known all over India. Dr. Nagori is the person who has, given such simple treatment in such a good way to every webinar. He gives his personal experiences. He gives special tips. Dr. Tanya, in one of the, conversations, I was just talking to her in Delhi or on phone. And I said, Tanya, what are you passionate about? She's Kamal ma'am's daughter, all of us know, and she's a brilliant personality herself. She said, Madam, I'm passionate about male infertility. I said, you come to perfection, you speak in perfection. So that's how we connected. Dr. Venu Gopal, I have been panelist in his own panels where he has been moderator. So I know what excellent questions he frames. So this is how we handpicked all our speakers. And I wanted that advantage to go to each and every one of our audience. Coming to our guests of honor, we are so delighted to have Dr. Ritu Khanna amongst us. Welcome, Dr. Ritu. Madam and Randhir and I, we have been associated since decades now. She belongs to Varanasi, and she is a person who does well in academics. She does well in her clinical part. She's a good teacher. I've seen her teaching in ICOG. She's a brilliant speaker. So at present, she's chairperson Foxy Food and Drug Medico-Surgical Equipment Committee. She did a brilliant ICOG certification course, I know, because I attended it. She's also the secretary. She recently won the elections of SFM. So that shows us she's passionate about fetal medicine also. She is the Central Executive Committee member of SFM and the executive member very active in UPCOG. Welcome, Dr. Ritu. Without wasting any more time, I would like you to speak to us and address us.
Yeah. Thank you so much, Dr. Monica, for those very, very kind words and, bringing me to this very, very prestigious Perfection series. Monica, as she said, yes, Dr. Randhir and myself, we've all been associated very long time. And I know Monica, she's too dynamic and I think very, very loving. So all the best wishes to you, Dr. Monica, and also to our vibrant MOCs who are here, Dr. Purnima and Dr. Manisha. I think they've been constantly updating us about the program. We're not to forget to be there for this Perfection series. And my heartfelt thanks to the whole SR team, Dr. Nandita, Dr. Amit Patki sir, Dr. Asha Bakshi, Dr. Charudat, Dr. Randhi, Dr. Fesi, and Dr. Pratik. And my gratitude to our chief guest today, Dr. P.K. Shah sir and Dr. Hema madam. Hearing to them and being with them is always an inspiration for us. And by regards to our co-chairs, Dr. Neeraj and Dr. Apur, we have a good time when we're working together. So, and I really love the concept, of this Perfection series today, the male infertility unrevealed. And I think, today it's a time, that a gynecologist, they really need to know more and more about male infertility. It's because of the advancement of technology. It's not that we need to do everything, but we are the first guide to the patient. So I think unless we are updated or unless we know, we cannot carry the concept forward. And the speakers, the experts in the fields, Dr. Sunil Jindal, I think the most apt that you've picked up. And going to the medical management, so many combinations, and it's always a quiz to solve. So there's no one else better than Dr. C.B. Nagori sir. Aging in males, you said Tanya, yes, she is very, very passionate, a very good and excellent orator, and we always love to listen to her. And so versatile, Dr. Venugopal, I think is going to drive you fantastically through that railroad of managing male infertility. And my best wishes to all the panelists and all the regards to our esteemed chairpersons. So thank you once again for having me here, and best wishes, Monica and Dr. Varsha, for all your endeavors. Thank you so much. Thank you.
Thank you, Dr. Ritu. Thank you for your kind words. Next, I would like to introduce our guest of honor, Dr. Neeraj Yadav. Dr. Neeraj Yadav has given me a lot of opportunity to work with him. He has invited me as speaker, as panelist, and through him, I came to know a lot about sexual medicine. I mean, I'm indebted to him because he was the one who made me realize it's such a huge subject. He came to Bhopal. That's the first interaction I had with him. And later we started working together in his committee. So he's chairman, Sexual Medicine and Cosmetic Andrology Committee, IASRM. He is also chairperson, Sexual Medicine Committee of FOXY in the years 22-23, and past president of Rajkot OBGYN Society, a very friendly, down-to-earth and humble leader. Dr. Neeraj, please, we would like to hear a few words from you.
Thank you, Monica, for your nice introduction. And thank you, Dr. Ranjit, also for inviting me to have this perfection series by ISAR. So this is I come to know this 11th episode of the perfection series. So congratulations, and I wish you will go at least do century in this perfection series. So coming to the today's and I can see so many faces. PK Sasar, Hema Madam, Pratik, Varsha, Dr. Sasibala, and so very nice to see them after a long AICOG. I think it is almost 1 month is there post AICOG. So happy to see them once again. And of course, Apurva is there. I can see now. So coming to today's theme is that is male infertility. So I congratulate you for thinking about today's topic, that is male infertility, because as I am in the field of sexual medicine since last 4 years because of my committee, and I can draw parallel between the sexual medicine and the male infertility because we as a gynecologist are not that much comfortable dealing with either sexual medicine or either dealing with the male infertility. Whenever we see a male infertility patient, it is very common, I have seen in my area at least, that they do semen analysis. If it is abnormal, they directly give some medicine to that. And if after 3 to 4 months there is no improvement, then patient go directly to the IVF specialist. We hardly try to examine such patient. We hardly do any investigation, and we hardly try to understand what is the basic cause of male infertility, and we try to manage, improve the semen analysis. But because there are so many lacuna in our knowledge about the male infertility, so I'm sure with today's session, we will come to more about what are the various factors and how we can improve the male infertility part in our practice. So congratulations once again for today's session, and I'm wishing you best of luck for today's session and for your whole future endeavor in the ISAR or as well as in the FOXY. And thank you for inviting me.
Thank you, Dr. Neeraj. Thank you very much. And Dr. Charu Joshi has just joined us. Before coming to Dr. Charu Joshi's speech, we would like to introduce our special guest, Dr. Apurva Kumar Datta. So he is a shining new star in the field of FOXY. Everybody knows Apurva. Apurva is everywhere. So he's chairperson, Sexual Health and STI Committee of FOXY, National Coordinator of Sexual Medicine Committee FOXY. He's holding big programs.
Thank you so much, Monica, ma'am.
And just after perfection, I have to join his Northeast program. I remember Apurva. He's a very strong person. We are so proud of you and your awards. I mean, it is so heartwarming to see, you know, a young gynecologist like
Thank
you
you.
doing such brilliant job in the country. Welcome,
Thank
Dr.
you.
Apurva.
Thank you. Thank you. Thank you so much. Thank
We
you
would
so
like
much.
you to speak a few words here.
Yeah. Thank you so much, ma'am. First of all, good evening to respected Dr. P.K. Shah, sir, dear Hema Divakar, ma'am, then Asa Bakshi, ma'am, Ritu, ma'am, and my mentor, Dr. Neeraj Jadhav, sir. When I got a call from Monica, ma'am, you have invited as a special guest. So I was just, oh my God. Few months back, I was like MOC, I was like coordinating, I was like convener of the all the webinars, and now it is now upgrade to the special grace. So thank you, Monica ma'am. Thank you, Randhir sir, for giving me the opportunity, and thank you to the all the ISAR, office bearer Amit Patki sir and Asha Bakshi ma'am for bring out this wonderful topic. I always watch the program by the ISAR, which is headed by Randhir sir and Monica ma'am. You are always doing wonderful. So I'm a great fan of yours program, ma'am. Now coming to just want to add few line about the male infertility, because many a time the patient are coming and we are actually forgot to ask a very important history, that is the sexual history. Now, why I am now a practicing sexologist also. Why I was so much into sexual medicine, because when as a male gynec, probably in my male patients are coming with the various sexual problem, and they are saying if they are suffering from last 5 years, 4 years, 6 years, and we are not open up to our gynecologist and saying our problem of the sexual problem, which is one of the basic reason of the male infertility. So I think when the topic is there, the male infertility, when the patient is coming, we have to ask about at least one sentence: is there any problem in the intercourse? So I think this is one very important topic which we all infertility specialists should know. So I think we have a wonderful speakers with us. I'm eagerly waiting to get a knowledge from them. And thank you so much to Monica ma'am, to Randhir sir, and all the organizer to invite me as a special guest. Thank you, thank you, thank you so much. Thank you.
Thank you, Dr. Apurva. And we are not going to leave you. We'll be taking you frequently because we choose the best diamonds in the whole India. So we'll be always, we'll be touching you.
Thank you, thank you, thank you, thank you so much. Thank you so much, sir. Thank you, sir.
Yeah, so, we see it like these people are reaching such great heights, Apurva, Priyankur, I mean, these young gynecologists, and yet they are so respectful to their seniors. So thank you, Apurva, for joining us today. Next, I would like to have the CD of Dr. Charu Joshi again, Dr. Vishal. And we welcome Dr. Charu Joshi from Indore, who has just taken over as Chairman, ISAR Embryology. Charu, sir, you have been introduced. You are the staff MP and our pride. And we would like to have a few words from you, sir.
Thank you, Monica Madam. Randhir sir, this is always a fantastic event which you organize always. And I will not take much of time because I was listening to so much of big stalwarts, and everyone is very eager to listen them and male infertility. I just want to say a few words about this male infertility and ISAR program under Dr. Amit Patki sir's guidance. Like every time it was used to happen that irrespective of the count, because initially when this male infertility started, we were just looking about the counts and motility, but there is a lot of things beyond count and motility which is now realized by the fraternity, and now the importance is given to male infertility. So the basic question asked by the patient when there is a negative result, that everything was fine, then why it has happened, and we don't have the answer. But probably after dealing with this male infertility in depth, probably we may have some answers to tell patient that this is the real problem, and that's why, like the DNA fragmentation, which was a very important aspect of semen analysis, which was ignored earlier, but now it is given importance, it has been diagnosed, and it has been done very well. And I just like to convey here that similarly as this ISAR Perfection series, now we are under Dr. guidance of Dr. Patki sir, we are planning another webinar series with the clinicians and embryologists to let them understand each other, like what embryologists want, what gynecologists want, what is the problem, why embryos are not formed, why the pregnancy has not happened, why the oocyte quality is not good. I think that is something which is much needed in today's era. And today we are very fortunate that, like you said, the young doctors and embryologists who are joining, they are more open for discussion and tell about the problem faced and then to find the solution. So without taking much more time, I would like to thank once again all of you and all the best for the fantastic series, upcoming series, continuing series, and very eager to listen all stalwarts. Thank you very much, madam.
Thank you, Charu sir. And I'm sure the embryology division of ISAR will progress as much as the clinical division. And we will more and more try to support each other and make each other grow, the clinicians and the embryologists. Now, whatever perfection you might see over here or with our programs, it would not have been possible without these two little twinkling stars of mine, Dr. Manisha and Dr. Purnima. All of you know them, all of you love them, and so do we. And they are the darlings of Bhopal. And they are Dr. Purnima Tiwari, a very brilliant student from elite institutes of the country, MAMC and LHMC. She is at present consultant of the IVF department of Apollo Sage Hospital, Bhopal. And Dr. Manisha is the treasurer of Bhopal Obstetrics and Gynae Society, very active in ART, MPOX, and, a brilliant worker, a silent worker. But they are forever, nudging me, prodding me, madam, do this, do that, let's do this. So, they keep me all young and prepped up. Thank you, Manisha, Purnima. So from here onwards, I hand over the program to them. And over to Manisha, Purnima to start the first session.
Thank you so much for your kind words. And you are always our inspiration and our mentor. And now let's move forward for our session. Ma'am, yeah. So, ma'am, the first session is by Dr. C.B. Nagori, sir.
Yes, we have a slight change because Dr.
Yes.
Jindal is busy in OT right now. One of his patients started bleeding. So Dr. C.B. Nagori is going to take the first talk and Dr. Jindal will be taking the second talk.
Yes. So, Dr. Vishal, please show the slides of second session.
Please. Madam, I'll take some time, 10:50, because my session is at 5 o'clock. I think madam is not here to adjust my computer. Wait for a few minutes, she'll be coming.
Okay, Monica, ma'am, you are muted.
Dr. Nagori is taking some time? Is it Dr.?
I think it was from sir only, ma'am.
Okay. Dr.
So till then, can
Dr.
introduce the...
Dr. Tanya is also there. I think Tanya can start the first talk.
Yeah, Tanya is.
Oh, yeah. So let's start session 3. No problem. Let's start session 3. Purnima.
Session, yeah, okay, ma'am. So, okay. So for our session 3, our chairpersons are Dr. Vaishal Arya ma'am and Dr. Bharti Maheshwari ma'am. Dr. Vaishal Arya ma'am is immediate past president, Nasik Obs and Gynae Society. She has been past organizing secretary of NOGS, past joint secretary IMA, and also we wish ma'am good luck for upcoming elections for Vice President FOXY 2024. I think ma'am was with us on this platform. So we welcome you, madam, today. And our next chairperson is Dr. Bharti Maheshwari, madam. Madam is President Merit Obs and Gynae Society. She is Professor and HOD of Department of Obs and Gynae at Muzaffarnagar Medical College. Madam has been Chairperson FOXY MTP Committee 18 to 20, Governing Council Member ICOG, and Secretary UPCOG. We welcome you, madam, today on this platform. And thank you so much for joining us today. Do we have Bharti ma'am or Vaishra ma'am?
Yeah. Vaishra ma'am is
Good
there.
afternoon, everyone.
I'd like to hand over the session to our chairperson for introduction and speaker. Thank you, ma'am.
Yeah, thank you so much. It's always a pleasure to be with all these stalwarts. Thank you, Dr. Monica, Dr. Randhir, and each and everyone from ISAR as well. It's my proud privilege to introduce Dr. Tanya Bakshi. Today, we could see that she's a very beautiful and a dynamic lady, and she would be talking on, of course, the male infertility. She has been associated director of IVF reproductive medicine and oncofertility Max Super Specialty Hospital in Delhi and NCR. She has received many most dynamic woman healthcare award, which is twice. So, and she's a recipient of ISAR Appreciation Award for her selfless contribution towards the field of ART. The most prestigious APJ Abdul Kalam Award in 2022 was given to her. She also has been awarded for the Safe Motherhood Champion Award. She has done a pioneering work in PRP, in reproductive medicine therapy at Max Super Specialty Hospital, and given a first live birth from intrauterine PRP. A really heavy.
Thank you so much, ma'am.
So many things. And over to you, Tanya. Good to.
Thank you so much, ma'am. Thank you. Can I be allowed to share my screen? It's not allowing me. It says I cannot share my screen.
Can you help?
Tech department, technical department, can you help, please?
Already, madam, I have stopped sharing. Already, I have stopped sharing.
Now you can try, Tanya. You will be able to share, I think. Are you able to share, Dr. Tanya? Tanya, your voice is also breaking. I think you need a better connection there. Or...
Can you hear me now? Can you see the screen?
We can see your CV slide. Yeah,
So
we can see.
Can you hear me now?
Yes, we can see your.
So thank you very much. Thank you for having me here to a very exciting session. And I'll start off by a question really. When we are addressing our couple, is really the topic
अरे यार
of
मैडम ने
father's
फोन
age,
करने क्या पहुंचा यार
is
सुन ध्यान से
father's age taken into account? Should I
एक
continue
बात सुनो
or does sir want to start?
अने
Can the host mute all?
Please continue. Okay.
Yeah, Tanya, you can
So,
continue.
we do know that this is a reality now, and just like we're seeing older women, we're seeing older men. But are we talking enough about the older men? I would just like all of you to have an open opinion about this. And at the end of the day, and at the end of my session, hopefully counsel our patients better, so that not only are we looking at the women through the lens of age, but adding that layer to the men as well. Now, why is this happening? We know that there's later age of marriage. The society has changed. We know that there's longer life expectancy. And again, India is on the news. So when I searched, as we would have it, the first, Ramjit Raghav, and the third in the top three are Indians. So right from 92 to probably 104 years is where we stand. And then again, we know last year, Robert De Niro was in the news again for being a dad for the 7th time. But if you were to see, the mums here are usually younger women. So we do know that there is an age impact for a woman, but there is also an age impact for a man. And if both are older, especially more than 35, then both act as a confounder for having abnormalities. So yes, there is an increasing trend of paternal age. There is effects which are less recognized. There is less information out there on the men, and we counsel the men much less than we counsel the women. I'm sure hand on heart, each of us, when we see an older woman, whether she's 37, 40, 41, we spend a great part of our consultation telling her what are the effects of her aging oocytes on the pregnancy and the outcomes that would have for the baby. However, when we see a man who's in his 40s, do we spend as much time? I think we need to. Again, as I said, that there is a residual confounding factors by maternal age. So there's a lot of heterogeneity in the findings that are out there. Most studies have said that advanced paternal age is about 40 or more. But more and more studies are showing, just like the woman, 30 age is a cutoff, especially 35 and beyond, where these effects start to kick in, and we need to be mindful that when we're looking at a couple, now we look at a couple's age. So if we have a woman more than 35 and if you have a man more than 35, we have both the confounders which add on to each other. Why is this happening? There are multiple causes there. As we know that there is a lot of divisions that happen in the testes. As you can see at 25, there are about 330 divisions and about 70, almost 1400 divisions. So the mutations accumulate through the multiplications and the errors rise, and these errors increase as the father's age increases. So there are a lot of factors, both genetic and epigenetic, and we know with the advanced age, there is a lot of epigenetic factors which are coming in and which again are influenced by environmental factors, by lifestyle factors. And I'm sure my other two seniors would be speaking a lot more about them, about DNA fragmentation, oxidative stress. But what I'd like to highlight, not only are we talking of chromosomal abnormalities, Y chromosome microdeletions, we're talking about de novo mutations, we're talking about base pair changes, single point mutation, microRNA changes, centomere aberrations, and even about the telomere. So there was a time where we talked about the telomeres, and we know with telomere elongation, whilst it might confer a survival benefit, it has its downsides, where most studies are linking it with cancers. Again, we know there is a theory of selfish testes mutation, which has come up, where we're saying that maybe if there are abnormal mutations, these just rise and testes becomes a bioreactor for these selfish mutations that promote neoplasias and complex diseases. So really, if you look across the gamut, right from the semen quality to the reproductive outcomes to effects of birth defects and morbidity, we're now studying and looking a lot about the public health risks and what is the morbidity of these young children who grew up to be young adults following ART. And now we want to add the layer with the paternal age. So what the studies have indicated, there is a decline in the semen volume, semen count, motility, morphology, fertilization capacity, and of course the DNA integrity. Hence, there is a decrease in the success rate, both with IVF and ICSI. I shall take you through that in a moment. Higher pregnancy losses, premature birth, stillbirths, low birth weight. What about the birth defects? Right from childhood cancers to skeletal dysplasia to syndromes like Klinefelter's, achondroplasia, to neurodevelopmental disorders, to even disorders like schizophrenia, autism, and bipolar disorders are on the rise. So this was a really nice paper which looked at the advanced paternal age and the risks, especially the genetic disorders in the offsprings. There was also one which looked at a public health risk. These are epidemiological evidences that we've seen which happen right across the various studies. What they looked at right from preterm survival and stillbirths, and this is a huge cohort of almost 1 million births from 1994 to 2010, what they found that there was a higher rate of stillbirth even after adjustment for maternal age. As you can see, while they compared with fathers 32 years of age, the risk was almost 1.2 times when 40 and 1.36 times when a father was 50 years or above. Now, the rare syndromes we've talked about, like achondroplasia, the thanatophoric dysplasia, osteogenic imperfecta. Then we have the Apert syndrome, Pfizer's, Cruzon's, Marfan's, neurofibromatosis, aneuploidies. We all know about the impact of the aging oocyte on the higher rate of Down syndrome. But now we know that there is an element which comes from the paternal genome as well. And especially when it comes to the 21 chromosome and the sex chromosome, especially Klinefelter's, there is an association being made with paternal age. In the childhood cancers, especially a higher risk of ALL has been seen. Moving on to neurodevelopmental outcomes, increased psychiatric disorders from autism to attention deficit, psychosis, bipolar disorders, suicide attempts, substance abuse, schizophrenia risk. However, there is still a very diverse etiology, and we can't pinpoint to one particular aspect of just the paternal age, but we have to factor this in the whole spectrum. Now, what they looked at, as you can see, they've seen the evidence for these risks. And if you were to look at the achondroplasia to the thanatotropic dysplasia, Pfeiffer's, Marfan's, neurofibromatosis, all these have a strong association. If you look at cleft palate, again, a strong association. In the childhood cancers, we have the ALL, which is strong. With retinoblastoma, we have a medium link. And again, with autism and schizophrenia, it is a strong link. So moving on, when we look at the fetal effects, we have various genes, right from the PTPN11, we've got the FGFR2, 3, and the RET genes, which cause the abnormalities as shown above. Again, achondroplasia, which is with the FGFR3 mutation, almost 2 times higher risk with advanced paternal age. So this was a very nice review and meta-analysis by Fang et al. In China. What they showed is, again, a moderate increased risk of urogenital cardiovascular malformations. This was quite interesting because they looked at the fathers who were younger than 20 years, older fathers of 40 or more, and their optimum range was 25 to 29 years. And as you can see here, the ones which had a strong link were the urogenital abnormalities. We had the cardiovascular abnormalities, the facial abnormalities, and the chromosomal disorders. Now, whilst I'm talking of advanced paternal age, I also would like to highlight that when we have very young boys as well, age less than 20, you can see the urogenital risk is quite high here. And if you can see, even the chromosome abnormalities here at less than 20. So I think very young, older, again, we need to think about both aspects. Another paper, which was a systematic review, which in 2022 looked at, this is a paper from France, again, impact of paternal age and on the aneuploidy rates. They said it can possibly, again, have the ART outcomes based on the paternal age, looking at all the spectrums we've talked about. You can see here, what is the nice thing here, they had a review study, they looked at the cohort and the epidemiological studies. And right from DNA fragmentation risks, if you were to see to the pregnancy rate, not only does it take longer for these men to father a pregnancy, but again, if you look at the miscarriage and the live birth rate, be it from 35 years of age to 40 to 50, you can see the risks here. Now, what they also looked at here, if you had a younger woman versus an older woman, how your live birth changes. So if she's more than 35 years, and if the man is more than 40 years, there's almost a 10% decline in the live birth rate per year. So again, something to be mindful of. This was very interesting. This looked at, okay, so we have an older man and you're going to do ICSI. Is there anything we can do to possibly use a lab parameter in the ART portfolio that we have to make better outcomes, and PIXI or sperm selection with the hyaluronic acid, which showed improved live birth outcomes. And again, maybe something we can offer to our older dads. And when we have a patient with older woman and an older man, then probably adding a PIXI in the lab would help improve our birth outcomes. So aneuploidy risk we talked about, especially 13, 18, and 21. This paper looked and found that yes, 50 years of age, but again, maternal age was a strong confounder. Again, looking at the infant risks, as you can see, if it's more than 50 years, the Down syndrome risk was much higher. Then we had the 21, 13, and 18, again higher in both the cohort and the epidemiological studies. And again, if we look at achondroplasia, Apert syndrome, all of them are higher risk. Here, if you were to see, we have the autism, we have the schizophrenia, bipolar disorders, OCDs, attention deficit, and even major depressive elements. I'd like to bring your attention, if you looked at the review article here, that there's a 21% risk per 10 years of paternal age between autism. However, there was another paper which found no correlation. So there are some grays here still, but if you see here for schizophrenia, the risks were higher even in young men, as we say, 36 or 37-year-old. So yes, potentially 35 for a man is as important as 35 is for a woman. So what about how do we counsel them? This was a practice paper which was in the genetics review in 2008, and they said that all these that we've talked about should be put into counseling when we have older dads. This is a lovely paper in BMJ, and what they looked at, yes, we do know with the ART, we do know the adverse outcomes in pregnancy, the perinatal outcomes, but how is advanced paternal age impacting both the mother and the offspring? So what they said that they already know that the age of the men is increasing. Both they have the paper from the United States, but we all know we get older men now, just like we get older mums. But what this study adds is that if a man was 45 years or older, there was a higher chance of having a baby born premature, low birth weight, low APGAR score comparing to the younger counterparts. If we looked at dads older than 55 years, they required more chances of assisted ventilation, admission to the NICU. But what is interesting here, if you were to see, that the odds of gestational diabetes for a mum, even if she's younger, was higher if the dad was older than 45 years. Now, if you see, they found almost 13% of premature births and 14% of low birth weights were born to older dads. And this, they feel, could have been prevented if the men had their pregnancies before 45 years of age. So just as we are counseling, right from the moment we say semen parameters, to the success with the IVF ART, to the pregnancy outcomes, to the morbidity in the children, it is a coherent stream of flow which starts out both with the maternal and the paternal age in mind. So to conclude, paternal age effects are there, but they are less recognized. Underlying pathophysiological mechanisms are not clearly determined. It's quite complex. As we said, it's an interplay of many genetic and epigenetic factors. Confounding factors, right from maternal age, lifestyle, ART itself, be it smoking, be it obesity, each of it impacts the success. The adverse pregnancy outcomes are there, and the ones associated are stillbirths, miscarriages, preterm births, low birth weight. Children with older dads are higher risk of genetic abnormalities, pediatric malignancies, neuropsychiatric problems. And we should offer detailed and scientific counseling for older parents, including the age of the dad undergoing ART. We do not know what will happen in the next 30 years, but we are sure that we would possibly see minor phenotypical effects as we have seen over the years with the maternal age. We will be seeing these impacts in future as well. Thank you. I'd be open to taking any questions if you had any.
Since Dr. Bharti Maheshwari has joined just
Yes,
now,
sir.
I think Dr. Tanya, after your beautiful talk, we would like to have the concluding remarks from Dr. Bharti.
My
And
pleasure.
any questions can be put in the chat box. And I'm sure Tanya would love to, answer those questions later.
My pleasure having you, Bharti ma'am, as well.
Yeah. Good evening, everyone, and really congratulations to whole team of PSAR who is organizing this Perfection series, especially related to male infertility, and Dr. Monica and Dr. Nandita madam and Dr. Ranveer and whole team. So, as this is a very important topic that we always talk about the female age and female infertility, mostly we counsel about that. And we always, most of the time we emphasize that whatever the age of the male, that it is okay. But again, as Dr. Tanya has emphasized by many evidences, that there are lots of issues that the age of male advanced. So definitely, there are certain the counseling points that we have to tell about, especially the prognosis and success rate of as the advanced age of the male. So there is definitely some sperm semen parameters they altered or changed, or sometimes besides the lifestyle changes of male, the age also matters. It is definite, and more research papers are required to have a more evidence. So it was a good lecture, Dr. Tanya, and to just sensitize all of us regarding the male age also. So thank you. This really matters. Age of male also matters.
Thank you for joining us, Dr. Bharti, from your busy schedule. We love to have you with us today.
Thank you.
So I think we move to the second session. Dr.
Yes, ma'am. Nagori sir
Yes.
Yeah,
is there.
sir has just called me. Sir has joined.
Yeah, so let's move forward for our second session. For our second session, the chairpersons are Dr. Randhir Singh sir, Dr. Beena Singh madam, and Dr. Sadhna Jaiswal madam. Dr. Randhir Singh sir has already been introduced. Sir is convener of this program. Dr. Beena Singh madam is honorary secretary of Bijnor Obs and Gynae Society. She is alumni of prestigious LRRM Medical College, Meerut. Madam deals in high-risk obstetrics, urogynecology, infertility, and gynae laparoscopic surgeries. Madam is also pet lover and interested in organic farming. We welcome you, madam, today on this platform. Thank you so much for joining us. Our next chairperson is Dr. Sadhna Jaiswal madam. Madam is president of Greater Noida Obs and Gynae Society. She is having experience of more than 3 decades in the field. She has received Petron membership PCOS Society along with several awards, and she is founder president of Mirzapur Obs and Gynae Society. Thank you so much, madam, for joining us today. So now I would like to hand over the session to our chairpersons. Dr. Sadhna ma'am, Dr. Beena ma'am.
Yeah. Good evening, everyone. Dr. Nagori, please, you're welcome to start your session. Dr. Nagori.
Thank you.
We are very eager to hear you, sir.
Okay, please allow me to share.
Just share my
Please
slide.
allow us to share, please. Yeah, thank you.
Good evening, Sonal ma'am.
Hi, Dr. Monica.
So, respected chairpersons and all the organizers of this program, I would like to discuss on the medical management of male infertility. All of you know that the 50% the male is responsible for male infertility. One of the very good thing in medicine is that there is always a history taking and then there is an investigation. This is the only branch of medicine where investigation is first and the history taking is afterwards. It is written that if the semen analysis is normal, unless the patient volunteers, there is no need to go into the depth of it. I think a lot of discussion went on before, but this is what the literature says, that once the semen analysis is normal, and if the patient does not complain you anything, then there is no need to go further for the analysis of the male. All of you know, to the 1999, then 2010, and then after that 2021 also, the 6th edition was also mentioned. So now, the 16 million being a normal count. Unfortunately, in India, more than 30 to 40% of the labs still write down 40, 60 million as a normal count. That is very unfortunate part. And I always tell that the prescription indicates the year of passing. When they had passed at that time 40 million, and they continue to write down the same. Endocrine workup, what we require as a gynecologist, the FSH, LH, and testosterone. These are 3 important hormones to be investigated. And being a gynecologist, only one hormone is important, and that is FSH. It will have 3 permutation combination, whether the FSH is high, whether FSH is normal, or whether the FSH is low. Accordingly, what you should do, particularly when the FSH is high, normally the LH is high and testosterone level is normal. These are most of the patients are for EID or adoption. Today, in the era of at present of ART, you may go for micro-TSA, but I tell you very honestly that when the FSH is very high, it is very difficult to get the sperm even with the micro-TSA, and all the centers do not have the facility of the microsurgery to be taken out by micro dissection. and particularly at periphery, in the centers where these facilities are not available. And third, very important thing is that you must discuss the patient the option of EID and adoption. So they should be shown the other side of the coin. If you don't show them, they normally agree for everything, whatever you say. But many patients will agree for AID and adoption because of the cost that is very high of the micro TCA. And second, the facilities are not available. So high FSH is either AID adoption or micro TCA. And same is for the high FSH with the normal LH level. These are the patients also you go for AID or adoption because primary spermatogenic failure. Very exception is a varicocele. I have seen second or third degree varicocele, particularly on the left side, have slightly higher side of the FSH with the azoospermia or severe oligoazoospermia. You correct the varicocele, stimulate, that we'll discuss later on, and you can get the good spermatogenesis in this patient. I told you this is for high. So whenever the FSH is high, it is AID or adoption, or very rarely you can go for micro TCA. When the FSH is low, it is hypogonadotropic hypogonadism. And in this patient, you can go with 5,000 units of HCG. HCG, that is LH, is required for initiation of spermatogenesis. And FSH is required to maintain the spermatogenesis. So here what we do, we try to bring the testosterone normal by giving HCG every 5th day. About 5 to 7 weeks they are given. And once the testosterone comes to normal, then we either give HMG or FSH thrice a week. And the duration is almost about 20 to 24 weeks. Remember, very rarely you get this type of patients in your whole career of your practice. You may get 2-3 patients, not more than that. But they are very rewarding patients. The improvement is almost 100% in all the patients. And that's why this is a very useful regime, that is HCG and FSH combination that is to be given to the patient. High testosterone, high LH. This is a very rare combination because these are the patients where if the testosterone is high, the LH is low, or the LH is high, the testosterone is low. But when both are high, this is because of the partial androgen resistance. And classical thing is when the patient enters the OPD, the patient enters with gynecomastia. So whenever you get any patient of gynecomastia, the E2 level is high, and that is because of the high LH and high testosterone level. No improvement is possible by anything, only whatever is available to you. Then you can either go for ART, or if the count is almost zero, then nothing can be done to this group of the patients. The most common factor that we see is the normal testosterone, normal LH, and normal FSH level. These patients are having azoospermia or severe oligoazoospermia. Rule out any of pathological condition. But majority of these cases, everything is normal. What you measure is by ELISA test, and that is an RIA level. RIA levels are normal. But the difficulty with this patient is that their bioactivity is very low. So all the hormones that you have measured are by RIA level, but there is a bioactivity which is very poor of FSH and LH and testosterone level. So they can be detected by monoclonal antibody testing, but that is not available with us. And you have to suspect that the bioactivity of this hormone is very low. And where you can go with FSH 75 international unit thrice a week and HCG 5,000 once a week. And duration is almost about 20 to 24 weeks. This is Professor Ishidori's regime. I am a fan of this regime. I've treated plenty of patients with this FSH HCG combinations, and I've got a very good success rate with this. We'll discuss in detail afterwards, but this is the wonderful regime that when FSH and LH and testosterone, all three are normal, there is no organic cause, then bioactivity of the hormone is poor, and if they are supplied from outside, then this can work very well. In a patient of male infertility, there is a specific and empiric therapy. The specific therapy, you know that if whatever is the cause, like hypogonadism, hyperprolactinemia, infection, once you know the cause, you can treat it very well. The disorders of ejaculation, immunological, isolated deficiency, congenital adrenal hyperplasia, this can be treated all because you know the conditions, and it can be treated very well. Like I've already discussed hypogonadotropic hypogonadism. Even formerly, there were the reports that the clomiphene acts on the hypothalamus, and here there is no FSH and LH. But there are various reports even on clomiphene citrate that before going for ICSI, you can have clomiphene citrate for 3 to 9 months, and it can improve the count so that either you can get the sperm in the ejaculate or you can do ICSI to this patient. Same way, HCG twice a week is very important. hyperprolactinemia, all of you know how to treat it. I don't go into the detail of it. These are the substances where, and nowadays, particularly electromagnetic field created by mobile and the laptop, that causes oligozoospermia, and the patient must be informed about it. The most common is empiric therapy. That is a treatment prior to final diagnosis based on the clinical concept and theory without proven efficacy. And idiopathic infertility is 25%. So the only available treatment for these patients are the empiric therapy. Any treatment is always empiric. Then after certain trials, it becomes the evidence-based medicine. Now I'll be telling you one by one which are the drugs which are used as an empirically and how far, what is the present status of using all these drugs. One is the clomiphene citrate. That is the cheapest drug. Only the subgroup is benefited. Insular has said that because it is the cheapest, it has to be tried to all the patients. So 12.5 to 25, the normal dose is 25 to 50 milligram. That should be given for 3 to 6 months. Particularly, very important thing is do FSH level, give clomiphene citrate. FSH, the clomiphene acts on the hypothalamus, it increases the FSH. So after your 1 month of therapy, if the FSH increases, your drug is acting. If the FSH does not increase, it means your drug is not acting, and the patient is less likely to have any improvement. So maximum 3 months are to be given. If your colleague has already given it for 3 months, there is no point in repeating the same drug for the second time. But there are a lot of studies that even for the surgical sperm retrieval by TESA also, that you can give CC prior to surgical retrieval and you can get a good number of sperm. HCG, the wonderful drug. I will say that one of the best drugs I have found in my practice is the HCG. For severe oligozoospermia, that you can use HCG twice a week, particularly 5,000 units twice a week can be given. And that is a very useful drug. The first reported study was 60% improvement, and these are the papers of 6382. Somebody may think that I have not read afterwards, but it is not so. There are no papers available after it, and that is the most drawback of the invention of IVF, that the drugs which can improve the count, the research has been completely stopped. The pharma companies have never financed the resources for the development of the drugs which can improve the count. And in Western countries, all finance is always given to the IVF and not to the drugs improvement. And that's why there are no papers available. Otherwise, so many other papers would have come up with the analogs of HCG and other things. But I tell you that I have used thousands of ampules of HCG in male infertility, where we get the wonderful improvement in the count. Very useful drug, particularly in the idiopathic oligozoospermia and the count. So clomiphene and HCG, because I know my practice when I started in 91, I had only 2 drugs available to me, and that was the clomiphene and HCG, and then the FSH came in the market. So we got excellent result. My only 2 family members also who had 3 and 4 million count simply improved with the HCG and the clomiphene. So this worked very well before subjecting the patient to ART, and particularly those who cannot afford ART, then these drugs can do marvelous job with them. HCG is very effective prior to TESA in the hypospermatogenesis also. So my carry-home message is that don't jump for ICSI to all the patient immediately, rather than you can treat it medically. So many patients will have good number of sperms, either in the ejaculate or when you do TESA, you will get good number of sperms afterwards, rather than before before giving any other drug. That's why these drugs are very useful for if they are given for 3 months. Then you can do TESA and then you can get very good number of sperms. These I've already discussed, the FSH plus HCG combination, that is for idiopathic normal gonadotrophic oligozoospermia. This was Professor Isidori's regime. I was very fortunate to listen his talk when he came to Bombay at Oberoi Hotel. There was a full-day conference on male infertility, and I was very fortunate to listen him. And he said that the bioactivity is poor, and that's why if you supply good FSH from outside or HCG from outside, then you can get a very good spermatogenesis. I'll discuss this in detail, but I have used to plenty of patients. My first paper I presented in Madras conference also for the 10 patients. I am very fortunate that because I used to have a lot of arguments with the people that the FSH and HCG, they are very empirical and not to be used. But if you go through the Fertility Sterility 23 February journal, the 5 to 6 articles are there only on FSH only. And the treatment improves the sperm retrieval after testing, also for ICSI, also for IUI, and also for natural conception. This is 23 paper that if you give FSH thrice a week to the patients, then the improvement of the sperm count can occur to majority of cases. And this is particularly even when the FSH is slightly on the higher side, because it has already damaged the spermatogenesis, then you can give FSH, which is biologically very active, and that can improve the spermatogenesis also. Particularly in the hypo and the normal patient, it is very useful. FSH and testosterone both are required, and that's why we always give FSH and HCG combination to all the patients. The Cochrane review with 412 participants receiving FSH reports significant improvement in the spontaneous pregnancy rate. So there are a lot of papers available in the literature that if the FSH is given to the patient, then it can have a lot of improvement. And second, even in the last ASHRAE, I think this paper was published. This was presented also regarding polytropin delta also. They have found out that by giving FSH to the patient, it can improve the good spermatogenesis. This was presented in the last ASHRAE. So FSH plus HCG combination, as always, the better result should be always tried in a patient of azoospermia or severe oligozoospermia. Particularly, the bioactivity is very low in this patient, and that can be very useful to the patient. So the ideal candidate are more moderate to severe oligospermatogenic dysfunction. And second thing is, it has been found out that in spite of high FSH, it can stimulate the spermatogenesis in non-obstructive azoospermia. Customary teaching was that whenever the FSH is high, then the drug is not going to act. But now it has been said that the FSH is high because of the damage in the testes. And this damage can be corrected by giving FSH to the patient, and that is very useful. And this was also the current paper which said that instead of 150, you can give 300 units of FSH, but because the dose was less, and they have found out better results with this. Those who did not respond to FSH in the previous study probably did not receive a sufficient high dose of FSH for the sufficient time. And that's why minimum 3 months are always required with at least 150. And in some of the patients, the 300 units are required for the patients. The fourth drug will be androgen. I just mentioned to condemn it that it's of no use. Mastrolone is used since long. People are still using it, but it has got no significance at all in improvement of the count. One of the best drug is tamoxifen testosterone combination. As such, testosterone is useless. But this is the only drug that is testosterone undecanoate, and that has been approved by WHO. And particularly, you give tamoxifen, that is 10 milligram tablet, BD can be given, and testosterone undecanoate 120 milligram. 40 milligram capsules are available 3 times a day, and that can be given for 6 months. So the improvement is 34% as compared to 10%. So it is almost 3 times more improvement. So this is also a wonderful drug. I've tried a lot, and it is very useful drug, particularly those patients who cannot afford ART, then this will work and you can convert it into an IUI cycle. Zinc, a very good drug, 120 to 220 milligram twice a day for 3 months. All zinc preparations were only containing 35 milligram only, thanks to COVID, that now the tablets of 100 or 200 milligram tablets are available because of it. Oligoastenospermia, the improvement is very likely to occur. Now I'll be telling you some of the drugs which we had used in the past, but now they are not used. But the only thing I would like to tell you that if the research would have been continued, this drug would have been with another analogs, it would have been very useful. And out of these are, one is the ketotifen, second is the anti-serotonin agents, that is the appetizer, which improves the count and motility 33 to 50%. What else do you want? Because even the IVF has 30 or 40% pregnancy rate with the first cycle. So if this improvement, a lot of patients can be improved by it. Captopril, antihypertensive drug, 1 tablet daily can be taken. But these are the drugs, the further studies are not available, and that's why now they are not used in the clinical practice. Anti-inflammatory drug, never try to find out the infection in the semen, and most of the time it is futile attempts. So instead of that, you can give doxycycline 1-BD for 14 days. And if it is a prostatic infection, then the quinolone groups of the drugs are seen. one word of caution is that whenever you get multiple reports of infection, it's not the infection, it is normally the premature cells. And patient go on taking the antibiotics for so many cycles. So be careful in differentiating the premature cells from the pus cells. Indomethacin, wonderful drug, 25 milligram 3 times a day, very cheap, non-toxic a drug which can be useful for improvement of the count and motility. Indomethacin can be used. Testosterone is very useful, and that the aromatase inhibitors, particularly anastrozole and letrozole. Now, if you see the current paper of this, that whenever the testosterone estrogen ratio is 10:1, and whenever the testosterone is low and the estrogen is high, then at that time you can use letrozole to this patient. The ratio will be corrected, and you will get the sperm in the ejaculate, even in a patient of azoospermia. A wonderful drug. I have found it so useful, particularly when I have got the testosterone level is low and the estrogen level is high. Then correct this 10:1 ratio, and you get the sperm in the ejaculate, and that will be useful for you for further management. Autocrine endocrine system, this is not available in our country. CRF beta endorphin can be blocked. Naltrexone is a wonderful drug, but it's not available in our country. The ROS has been, all of you know very well regarding the ROS, that is an endogenous and exogenous source. And all the time ROS is not wrong. Physiological role of ROS is for capacitation, hyperactivation, acrosomal reaction, and the sperm oocyte fusion. So that is also useful, but when the level rises, then it becomes pathological for the DNA damage and apoptosis. So antioxidants have received the great interest in the recent years, but remember they have got the complementary to the conventional treatment. They cannot do any magic to you, but they are definitely very useful for the complementary treatment, particularly after varicocele ligation, after antibiotic therapy for infection, or anti-estrogenic treatment. At that time, simultaneously, you should give antioxidants to the patient. That will be very useful. Simply by writing antioxidants, they are not going to be useful to the patient. High doses of antioxidants have theoretical adverse effects, and that's why multiple drugs should not be prescribed to the patient. And any vitamin therapy, particularly B complex, has got a questionable role in male infertility. So there is no role of vitamin A, there is no role of vitamin B complex, have also got no role and should not be prescribed to the patient. Now, antioxidants are very useful in oligoastenospermia, unexplained male infertility, leukocytospermia, particularly more common with diabetes, smokers, and alcohol consumption. These three things are very common in our patients, that either they are diabetic or maybe a good smoker, heavy smoker, alcohol consumption, that it can be very useful. It is useful after the varicocele ligation or even the first degree varicocele, particularly when the motility is low, then the antioxidants will be very useful. You've got tocopherol, astaxanthin, lycopene, carnitine, and coenzyme Q. These are very useful. All others are also used in practice. They reduces the DNA damage, improves the chances of pregnancy by IUI. Still, it's a controversial subject, but I never go for DNA fragmentation test to my patients. I always go for antioxidant therapy to the patient, because whenever the DNA damage is very high, you require testicular sperm, and ultimately the cost increases to the patient from all angles. So it's better to give antioxidants to these patients. Vitamin E, very useful, and instead of that vitamin E, now all of us are using astaxanthin, which is very potent. So this is a very good drug as far as the antioxidant is concerned. Vitamin C, you require 1,000 milligram per day. Vitamin B12, 1,000 to 1,500 microgram. Why I'm emphasizing the dose? Because when you select combo preparation, then it should have 3 to 4 drugs in a therapeutic dose. Otherwise, when you see everything in homeopathic dose, I have seen some preparations where vitamin B12 is only 5 microgram or 10 microgram, which is useless. There is no point in adding vitamin B12 to the drug. So be careful when you analyze the drug. 3 to 4 drugs should be at least in the therapeutic dose. Folic acid, because it is a multiplying cell, and that's why you require a supplementation of folic acid as an additive drug. Pentoxifylline, not much useful. Selenium, a wonderful drug, that 85 milligram microgram is normally the dose in majority of the combo preparations, and you require to give the tablet 3 times a day. 50% patients improvement is possible with this selenium, particularly for motility. Lycopene and carotenoids, 2,500 to 5,000 micrograms are normally available in a good therapeutic dose, and that can be given for 3 to 12 months in oligosteroteratosphermia. Glutathione daily injections are very cumbersome and not to be given to the patient. L-arginine 4 gram per day. The capsules available are 500 milligram, and nobody is going to take 8 capsules per day, and that's why that is not to be used in practice. The wonderful drug is the L-carnitine plus L-acetyl-carnitine. This is a wonderful drug. Even the Human Reproduction have got 4 to 5 papers starting from 2008 onwards. There are papers available on it, that this is very important role in the cell metabolism. The only thing is that L-carnitine and L-acetyl-carnitine are very useful in idiopathic oligosteroteratosphermia and the low-grade varicocele. Now, what is to be remembered for this patient, that particularly all these drugs, the positive effect does not last after the therapy. This is very useful because you can't prescribe the drug, ask the patient to come out for 3 months, and then you can try the treatment, either your IUI or IVF. It should be given simultaneously when you are treating the patient. So in a oligosteroteratosphermia, L-carnitine plus L-acetyl-carnitine sachets are available, and this has got a wonderful drug. Same is also the coenzyme Q. 100 milligram BD is the standard dose. There are various other tablets, 200, 300 milligrams are available, but the standard treatment is 100 milligram BD should be given to the patient. And this says also the same thing, that the positive effect does not last for a long time. So whenever you are doing your IUI or whenever you are doing your IVF ICSI and you want to have an improvement in the motility, then simultaneously the coenzyme Q is to be given. And then you should treat the patient very well. There are other natural sources, all of you know very well. I don't go into the detail. Vitamin D, there are studies that have shown that the low vitamin D causes the poor sperm motility, but still the standard papers are not available. But there is nothing wrong in giving vitamin D tablet rather than investigating a patient, which will be much, much cheaper than the investigation. Same is omega-3 fatty acids, that is also very useful, and that can also improve in the spermatogenesis. So what I would like to emphasize, acupuncture, yet to be documented, and traditional Chinese herbal medicine have got no role. So don't spend the money of the patient unnecessarily to all these things. So what I want to emphasize, my carry-home message is there are a lot of drugs available for asthenozoospermia. There are a lot of drugs available for oligozoospermia. If both the defects are there, then you can find out which are common to this. Otherwise, you have plenty of drugs for asthenozoospermia. You have got plenty of drugs available for oligozoospermia, and all are evidence-based. A lot of trials have been done. You can select few drugs, can improve the sperm count to the patient. This is simply a revision of your doses: clomiphene, HCG, FSH, tamoxifen, and zinc. These are to be given to the patient. Then indomethacin 25 milligram 3 times a day, anastrozole 1 milligram, and letrozole 2.5 milligram per day can be given. Vitamin E 300 to 600 milligram, selenium 225 milligram, L-carnitine plus L-acetyl-carnitine, coenzyme Q, astaxanthin, lycopene, vitamin D, and alpha-linoleic acid. So the medical management of oligozoospermia is the most neglected segment in an infertility and managed today in the era of IVF and ICSI. Because nobody wants to improve the count. The patient is straightway taken for IVF and ICSI. And I would like to tell you that you can convert an ICSI cycle into IVF, IVF into an IUI, and IUI into a natural conception simply by improving the count. Suppose the count is 2 million, I don't want 80 million count, but even if I can go up to 10 million count, I can convert that IVF cycle into an IUI cycle, and I can get a good result. I would like to tell you only a one case report that will emphasize the medical management. And this was the patient industrialist, 9 years of infertility, semen count 3 million. It was IVF and ICSI, 7 ICSI failure. The patient came for me with the 8th ICSI. I would have been stupid if I would have done the 8th ICSI, because all 7 ICSIs were done by the pioneers of IVF and ICSI in India. And in spite of that, patient did not conceive. So I always teach my students that always try to emphasize the try to revise the prescription of your colleagues and try to find out what they have not done rather than what they have done. We are more interested in what they have done, but try to find out what they have not done. And I could see that all 7 consultants who were the giants in this field, nobody had tried to improve the count. And I explained the patient that I would like to improve the count and I could improve up to 22 million. This is the example of Professor Ishidori's regime, where FSH thrice a week and HCG once a week was given to this patient. Patient conceived after IUI, baby boy, and because the count had gone to 22 million, spontaneous conception after 2.5 years, and the 7 ICSI failure has got 2 babies. I've got plenty of such examples who have improved the count, have conceived with IUI or ICSI. So that's why don't underestimate the value of medical management to the patient, because all of us nowadays, we don't have patience, patients don't have patience also, and nobody would like to wait. And that's why people subject to ART and the immediate treatment to the patient. But if you can wait, you can do a good counseling with the patient for male infertility, you can get good results also. Thank you very much.
Thank you very much, Nagori sir. I think you have dealt with everything which I have, and in the end you told that 7 ICSI done and 8th IUI normally you have conceived. I think that message should go, because sometimes the patient wants that, sir, I want a baby very soon, and they think that IVF or ICSI is the fast shortcut.
Yes.
So you have explained very well the part what I was saying, that being a legal, that patient should not sue the other ICSI giants in the court. So I think counseling is always a very good part, and you should always say, and in my practice, sir, what I have said that, I don't know, but now youngsters are very good. I always say कि इससे पहले जो हुआ है ठीक हुआ है, डॉक्टर्स ने अपने विवेक में किया है, मैं अपने विवेक में कर रहा हूं, और ये ऑप्शंस हैं. सो आई थिंक तो पेशेंट को खुद रियलाइज करने दीजिए कि वो जल्दबाजी में था. He did not come to a proper doctor at a proper time. So thanks a lot, sir. And I think other chairperson might ask the questions. Yeah.
Dr. Sadhna madam, Dr. Beena madam, any concluding remark from your side?
Yeah, it was a wonderful talk, Dr. Nagori, and especially you have touched all the aspects, the clinical tips, and very correctly you have said that nowadays patient also doesn't have patience, even the doctors. So many IVFs are being non-indicated cases also being done. Incidence of male infertility is surprisingly very, very high, maybe because of the stress, the pollution, especially I would see in Delhi NCR. And there are many factors, electromagnetic fields and all. So I'm very glad, and I must congratulate the organizing team for selecting this pertinent topic. Thank you so much, Dr. Nagori. And very clinical tip, especially also you mentioned about the pulses. We keep on giving doxy for teenagers के लिए, पर उसके बाद भी उसका आता रहता है, and premature cells need to be checked. So many clinical tips I cannot mention in short time. Thank you so much. Very elaborate and very excellent talk. Thank you.
Thank you very much.
Thank you, Nagori sir. Thank you, Sadhna ma'am, for joining. Thank you so much. It was wonderful having you as chairperson today.
Ma'am, can I ask a question from Nagori sir? It's
Yes,
time
yes.
for.
Yeah, sure.
Sir, Pranam sir, can you please elaborate regarding use of FSH in late maturation arrest?
Late maturation arrest, that is also known as a Schwarzman reaction. Here you can give FSH, particularly when the arrest is at the spermatid level. Then it will be useful. If the arrest is at primary spermatogonia or secondary spermatogonia, nothing will work. But otherwise, you can give FSH 75 international unit thrice a week. It should be given at least for 12 weeks. Then the improvement can occur.
Okay, sir. Thank you so much.
Yeah, Shashi Bala, doctor, I'll add to this. I had a talk in ACE Bangalore 2 months back, and now the technique have come that Nagori sir also will highlight that even the spermatids, round cells also in the world, we are doing ICSI, and few pregnancies have come. So the technology is advancing. We need a special ICSI needles for a larger bow, but round cell spermatids also, the pregnancy are seen in the world.
Okay, thank you so much, sir.
Thank you so much, sir, for such a wonderful talk. Now can we move forward for our next session?
Allow me for screen sharing. Actually.
Sir, you have to stop sharing your screen, Nagori sir.
Yes, sir. Yes.
Yes, sir.
Welcome, Dr. Sunil. to ISAR Perfection Series.
Yeah, thank you very much, Dr. Monica. I'm so sorry for being late. I was just stuck up with the case, so I could not reach. And
I
thank
hope
you,
the-
Dr. Nagori, and thank you, Tanya, for being so prompt
सर सुनील
to
सर
fill in the
आपके तो
space.
दर्शन हो जाए सर हमारे लिए दीदार काफी है सर तो
नहीं,
जब भी आए जब भी समय रहे सर
So, for our next session, our chairperson, Amita Shah Madam, Dr. Monica Singh Madam, and Dr. Alka Bishnoi Madam. Dr. Monica Singh Madam has already been introduced, and Madam is the convener of this series. Dr. Amita Shah Madam is President of Baroda Obs and Gynae Society. She has been Honorary Secretary and Vice President of same society, and having a special interest in adolescent health, menopause, and infertility. Right now, Madam is busy with her OPD, and probably she will be joining us soon. Dr. Alka Bishnoi Madam is President Bijnor Obs and Gynae Society. She is also Founder Secretary of the same society and also alumni of SMS Medical College and SN Medical College, Agra. We welcome you today, Madam. Thank you so much for joining us today. Now, I would like to hand over the session to Dr. Alka Madam for the introduction of our speaker.
Yeah, good evening, everybody. It is a great pleasure to be with you all in this prestigious Perfection series. Dr. Jindal is a renowned andrologist in our area, and he doesn't need any introduction from me. So we'll invite Dr. Jindal to please deliver your lecture, sir.
Thank you very much. Thank you very much. And thank you, Dr. Alka. Thank you, Dr. Monica. Thank you, Dr. Randhir. Thank you, everybody over here. Dr. Charu Dutt, I can see. Dr. P.K. Shah, I can see. Dr. Amit Patki probably was here too. I'm a bit late, but I'll just begin my talk right away. And I have tried to I've tried to make this talk over here where I could very, very simply for a gynecologist, bring out all those things which would be the best, the simplest. And so I'll just bring in, I'm going to talk about 6 things over here. So one is the way WHO has updated its reference limit. So for the basic thing for everybody is to know that the semen analysis which we normally get in our clinics are different from the way the semen analysis actually should be done. And number one, how can we adopt and interpret the new standards? The second thing is that apart from the semen analysis, there are a few tests which go beyond routine analysis. And let's learn about these tests. Third, antioxidant supplementation is a hot issue in male infertility. Let's understand its rationale, its use, and how can it benefit patients. Let's know that today 1% of this population is azoospermic, and about 70% of these people can be their own biological fathers. What is it available to us? And of course, in the end, spermatogonial stem cells form a way by which a lot of these people who are non-obstructive azoospermia will be treated in the future. So let's just understand that simple, what we normally call a semen analysis, may be judged as something very simple, but it is something absolutely complex. And in any semen analysis, the functionality of the sperm is more important than just the number. So you may see a lot of times that there may be people who have a normal sperm count, but they have idiopathic male infertility. And despite that number being there, that functionality of the sperm is not enough to give a pregnancy. Antioxidants have opened up in a very different way. They have opened up a whole new box of theories, how they should be used, what are the best to use, how scientifically we could understand their usage could benefit our patient. And azoospermia, where 70% of people could have their own babies, what all is there to offer to azoospermic men? And of course, the future, the way it would be for every person who has male infertility is extremely bright. So whenever a patient comes to our clinic, we know one thing for sure, that all these patients come to us without their husbands at times. The most important thing is that the man and the woman both have to be there. And the cornerstone of treatment is the man, who contributes about 50% of the infertility. So if we look over here and we look at the way the whole story of the WHO criteria is, it never says that below this you can't have a baby and above this you can't have a baby. All it says is that they have given a percentile, and that centile of 5% is what they have kept as a cutoff. So this is an older slide. I'll put in a new slide in which the volume was 1.5, sperm count was 15, sperm count per ejaculate was 39 million, motility 40%, progressive motility 32%, 4% and 58% vitality. Now I'll just put in a new slide. This was the old slide which was there, so I've just let it go. And 50, but let us also get that the percentile of the 50% is very different. So let's not confuse issues and say you are in the normal count and you are in an abnormal count. Now, over a period of time, the lower reference value, which is the 5th percentile, has gone down from the time of 1980 to 2021. Now, has the sperm count gone down? Has the criteria gone down? Is the way we look at things, has it gone down? Or has WHO decided that it should be such? Because a lot of pathology laboratories even today give a normal count as 60 million. And what I'm saying to you is something which really needs to be looked in and understood. So if we look at the 5th percentile in the WHO 2010 and WHO 2021, we would realize that there are very minor changes which have taken place. And the minor changes which have taken place are in volume, concentration, motility, vitality. But one thing very important in 2021 is, though I have taken a full lecture in ACE on this, explaining the WHO 2021 semen analysis only. Number one, they have included sperm DNA fragmentation as a test which could be done after this test. And the second thing which they have included is the Asiatic population, which was not included in the 2010. But the Asiatic population still does not have Indian population, because there is no major study from India which was there which could be accepted and placed there. So the new WHO standard takes the lower cutoff as the 5th percentile. It does not say it's normal. Below this, you can't get pregnant. Above this, you will get pregnant. And the population studied was recent fathers and their time to pregnancy. And time to pregnancy was taken as 1 year. Now, let's understand the sperm morphology. I get a lot of queries from people whenever I go to take a lecture. Okay, has the sperm morphology gone down? No. Sperm morphology has not gone down. The criteria has changed. Earlier, the criteria of something which was understood as normal was different than what it is now. So now if you take the Kruger criteria, the measurement of the head width, head length, midpiece, tail needs to be as per a proper micrometer measurement. And if this measurement is not correct, you will consider the sperm to be abnormal. So because the criteria has become strict, 4% morphology is considered as normal. The criteria was not this strict earlier, therefore the morphology was different. Now, WHO standard interpretation. Now, this is something which I have repeated earlier. Every laboratory should follow doing their semen analysis as per WHO criteria. And to do this, you need to stain the slide and see 200 sperms to see the morphology. And normally, you also have a grid in your microscope by which, in case you want to, you can measure the sperm. So, this is a very important thing for anybody who's doing a semen analysis. Now, are there any tools which we want to get done? So, this is the second thing we're going to talk about. So, there are a lot of tests available, but I will only talk about 3 tests which are clinically relevant. One of them is sperm DNA integrity. The second is reactive oxygen species. And the third is Y chromosome microdeletion screening. Now, sperm DNA integrity testing. I've been very fortunate that our group has had about 16 publications in the last 2 years, of which I have been a part of the publications. And we've had 2 major review articles on sperm DNA integrity testing. And these 2 articles have close to become the gold standard of the review of sperm DNA fragmentation. So let's go into very, very simply what it is. So the background is that normal sperm chromatin is essential for a paternal genetic transmission, we all know. Basically, sperm is a carrier which is carrying genetic material to the egg. That's what it is. Now, in case the DNA integrity is not right, what is going to happen? You'll have unexplained infertility, you'll have recurrent pregnancy loss, you'll have poor outcomes in IUI and IVF. Now, what's the principle? The principle is quantification of sperm DNA breaks. What's the specimen? The specimen is semen or spermatozoa. What are the tests available? Tests available are a lot, but 2 tests which are there, which commonly are done, are the tunnel test, and the second test is the halo test or the SCD test. Now, why do a sperm DNA fragmentation? So if you look at the live birth rates by intrauterine insemination, if normally you could get up to 19%, though 19% is very high pregnancy rate, if the sperm DNA fragmentation is elevated, it could be only about 1.5%. And when you go ahead with an ICSI, the percentage could be 26% for IVF, but enhances with ICSI to 42% because the maternal cytoplasm is there to repair the DNA. And number 2, the sperm is not subjected further on to even more DNA damage or stress during IVF, which could be there. So the quickest and easiest way is the halo test. And now a very important thing about sperm DNA fragmentation is that there is nothing like a normal less than 30%, more than 30, 35% R cutoff. After you have, over a period of time, done a standardization in your lab of about 200 patients where you have done the halo test, you would really understand if the standardization in your lab would be 30% or 35% for the DNA fragmentation. Now, Y chromosome microdeletion, one of the most interesting and important tests which you could need. So the basic thing is that the deletion is linked to spermatogenic failure. You can get it done from a blood sample. You would get it done in severe oligozoospermia or non-obstructive azoospermia. The testing is the PCR of the long arm of the Y chromosome, the specimen I have told you, and you diagnose the predictive value of sperm retrieval and pregnancy. So if you get a sperm DNA fragment, a Y chromosome microdeletion done, and the deletion is in the AZFA deletion, there is no retrievable sperm. AZB, there is no retrievable sperm. But AZC, you're going to get retrieval in about 70% of cases. I have this large series of retrievals because this is what we do very often. And in non-obstructive azoospermia, a reasonable number of patients have a Y chromosome microdeletion, And if they turn out to be in the AZA or B area, they are actually saved off TSA or micro TSA. So, and in case they are in the AZC area, you need to counsel the patient to say that in case a son is born, he is going to have the same problem. So it becomes a test which you cannot miss out in any azoospermic or severely oligospermic patient. So I've spoken to you about the tests which I relevantly would like every gynecologist to know. Now I'll talk about the oral antioxidant therapy for male infertility. We had about 4 papers published. One of them was the MOSI trial. And in them, but before that, I'll come to what the Cochrane review says. So in the Cochrane review, they found that those who were given antioxidants, the live birth rate and the pregnancy rate was significant, and the DNA fragmentation was less. Now, this is a very, very interesting thing for us to understand. That about 30 to 80% of infertile men have elevated markers of OS, oxidative stress. So whether it is prolonged stasis of spermatozoa in the epididymis, male accessory gland infections, immature spermatozoa, whether it's the environmental lifestyle factors like drugs, smoking, pollution, systemic pathologies like diabetes, cancer, or systemic infections, spermatozoal dysfunction takes place, which leads to infertility, and it is one thing which needs to be evaluated. So when a man comes to you and the gentleman has the sperm count which is normal and still pregnancy is not taking place, the woman is fine, and you label it unexplained infertility, there is a very high chance that the problem may be because of the oxidative stress. Now, when an oxidative stress, the history which you're going to take is whether he has a varicocele after examining him. Is there any genital infection, smoking, medication, drug abuse, systemic disease, pollution, or radiation? But how would you differentiate between sperm and leukocyte source of ROS? Well, you're going to test them for leukocytosis. And if leukocytosis is present, leukocytosis is one major reason because of which oxidative stress increases. Now, which antioxidant will you select? Now, this is a very interesting question because I'll share this with you. There are a lot of antioxidants which have been tested over a period of time. They have been given over a period of time. There are a lot of combinations in the market. People come with a lot of combinations every day with so many things in the combination. But 2 important things which are there are the dose in the combination should be appropriate, number 1. And number 2, it should be given for at least 2 to 3 months and could be continued further on. Now, with all the literature and everything which I have seen, what probably are the best 2 antioxidants are vitamin C and vitamin E. Vitamin C is water soluble. Vitamin E is oil soluble. And both these have a dosage of 500 milligram and 400 milligram. Folic acid is one drug which is very important for DNA damage prevention, not only in the sperm, but also in a pregnant woman when you give it for the fetus and the embryos, basically the fetus. Zinc, 25 milligram is the standard dose. Selenium, 26 microgram. So I've given you the drugs which are the basic important medicines. Astaxanthin is 8 to 10 milligram. Coenzyme Q is 100 to 200 milligram. Lycopene 2.5 to 5 milligram. L-carnitine 1000 milligram. Now, No company promotes vitamin C and vitamin E, but mainly the reason is that they are very cheap and it does not turn out into any kind of an ROI in these drugs. But whatever antioxidant you give, you should be clear of what is the dose and how much you plan to give the person. So now let's come on to azoospermia, which is the fourth thing I'm going to talk about. It's not synonymous of sterility. Complete absence of sperm in the ejaculate is azoospermia. It's 1 to 3% male population and 10 to 15% of male infertility. It's massive. And mainly there are two types of azoospermia, an obstructive azoospermia and a non-obstructive azoospermia. Obstructive is when obstruction will take place and spermatogenesis is normal. And non-obstructive is when spermatogenesis is deficient or absent, and there are a lot of reasons why it could be there. So how do you do sperm retrieval? The sperm retrieval could be done by a PISA, which is very commonly done. It could be done microsurgically by opening up the epididymis and taking out sperms from that, which is called as a MISA. It could be TISA by a needle with a 19 gauge butterfly needle and a 20 ml syringe. And normally for a PISA, you use a 21 gauge butterfly with a 10 ml syringe, or a Rita with a 23 gauge needle. And of course, TISA, which is sperm extraction, and micro TISA, which has become the gold standard for non-obstructive azoospermia. So I've just put in these videos. I hope on Zoom they could be seen. They may come as broken videos, but well, fine. So whenever you do a PISA, the importance is that the epididymis, you've got to go into the fullest part of the epididymis. You could use a BD syringe, not a 20, and in this BD syringe, you could give suction and take sperms out. And these sperms would then be used to find if there are any sperms present in the aspirate. Now, I'll tell you two things important. In any patient who has a non-obstructive azoospermia, please do not put in a needle into the epididymis, because the moment you put in a needle in the epididymis literally forever gets non-patent. And in non-obstructive azoospermia, there are a lot of conditions like varicocele and patients in whom there is a hormonal problem that probably spermatogenesis may take place, and probably a few sperms may be there which could come as a cryptozoospermia sample. So the moment you put in a needle in a non-obstructive azoospermia, you have finished that chance forever. So please do not put in a needle if you suspect non-obstructive azoospermia. Non-obstructive azoospermia, please open up the testes and take a biopsy. And either do a TISA or a micro TISA or a needle biopsy. Now, in case you have not been, this is PISA, sorry, what is written over here is incorrect in this slide. In a PISA, you would normally use a 21 gauge butterfly, a 10 ml syringe. The advantage of this technique is that it is more comfortable and maneuverable. So when you hold it and you put in pressure, you would clamp the tube, take the specimen out, and see if you are able to get the material in which sperms could be there. Now, the next is TISA. TISA could be a window system or a window biopsy. You just give a very, very small incision, open up the testes, take out a small bead, send it, and close it back and put a band-aid. So this could be a window biopsy, but this would normally be done when you think there is hypospermatogenesis or the person has obstructive azoospermia and the PISA has not given us a sample. Now next is a testicular biopsy. This is a very old video of mine. This video is about 12 years old. So this was a patient who had undergone a testicular biopsy somewhere else, and we did a multiple biopsy. And in this multiple biopsy, we took out the testes and gave multiple biopsies 4 above and 4 below. Just 1 minute. 4 above and 4 below. And these specimens were then taken to see in a non-obstructive azoospermia if there was any place where sperms could be extracted. I don't use this procedure now anymore, but I had to show that in case you do not do micro-TSA, then multiple TSAs or specimens could be taken out in a non-obstructive azoospermia. So micro-TSA, which becomes the gold standard, is when you bivalve the testes, open up the testes, and under a microscope, see if any tubules are there which are thicker, bigger, which you can open and take out. Now, in a micro-TSA, you go into different layers. First, the superficial layer, as you can see here, and then you would bivalve the testes to go into any kind of a deeper layer. Now, this is how a micro-TSA is going to look like. If you see the rest of the tubules and you see this tubule is a thicker tubule than the other tubules. And then this tubule would go into the laboratory and you would search if any sperms are there. If these sperms are there, then you'll take them up for ICSI and use them for ICSI. So sperms in a testicular sample are going to look like this. This was, sorry, not a testicular, this was a PISA sample. And you normally would find a lot of RBCs as they are there. You would also see some sperms. And you would normally try to pick up one of these sperms. So these are just a few patients which were there. So we in the last couple of years have had non-obstructive azoospermias. So this was a very interesting patient and I'll just bring it to you. He was, and this is a very old patient. This was, I think about now the children are about 14 years old. And the gentleman was married for 4 years. He had small testes. FSH was less. Facial hair were less. Testosterone was down. Started him on SCG. When the testosterone became normal, we started him on FSH, HMG. We got finally sperms. First ICSI failed. Sperms were very less. Second ICSI were quadruplets, did fetal reduction, and gave these 2 beautiful babies. Now this, I think this is about 15 or 16 years back. In fact, me and Dr. Anshul look very different over here. But I wanted to bring out this over here is that in azoospermics, hypogonadotrophic hypogonadism have a fantastic chance of having their own babies by medical treatment. Now, there was a whole lecture of Dr. Nagori, which was a beautiful lecture. But I hope you have been able to understand, but I'll like to bring out one thing, that you shouldn't take a wrong message of giving HCG and FSH to every patient of oligospermia or azoospermia empirically. That is not what he meant. In fact, the only meta-analysis available for this was in 2015 by Santi. And there were 16 studies which were taken up. And I don't remember exactly, but there were 600 and 700 patients only. And even that meta-analysis says one thing very clearly, that most of the studies done were biased. Most of the studies did not have a proper control. And most of these studies were such that today it cannot be said for sure that in any case, giving it empirical is going to help. But I like to bring out over here that 2 places the evidence says that it is a level B evidence where it can help. Number 1, in hypogonadotrophic hypogonadism. And number 2, in any situation where the patient has a low testosterone because you cannot give these patients testosterone. You want the intratesticular testosterone to be normal. So you're going to give these patients HCG. Now, as far as FSH is concerned, FSH normally in a patient who has very high FSH does not help. But it helps in the condition where you have started HCG and the FSH level starts falling down. Because what happens is that the feedback from the brain decreases, goes down. In these patients, you can add FSH. So that is a position which clinically you need to understand. And I'm sure Dr. Nagori meant the same thing, and he has a very vast experience. But what literature and evidence says today that HCG and FSH have a role to be played, but very cautiously, and you really need to think if you need to give it empirically. Now, non-obstructive azoospermia, this was, I think about 12 years back that we did in a patient cancer survivor, we took out this non-obstructive azoospermia and did this patient. So in this large structure, I have spoken of 4 things. We've spoken about the semen analysis, what other tests are available, antioxidant role, azoospermics who can have their own children, and what are the future perspectives of male infertility. So the future perspectives are going to be sperm biomarkers as a diagnostic tool, prospects of male fertility preservation, stem cells as a new agent of treatment of male infertility. With genetic testing and current diagnostic tests, there's a large population which still has not been able to, we have not been able to find genetically what is the problem. And if we know this by the genome, we would be able to develop a panel with which we could know pre-TSA what is the prognosis of these men. So, biomarkers. Well, in case there is any man, what is a biomarker? A biomarker is that whenever protein is forming, you have a lot of metabolites. And if you could measure these metabolites, you would come to know if these metabolites could give you an idea. These metabolites, if, like for example, PSA for prostatic specific antigen for prostatic cancer, you would have CA125 for ovarian cancer. These are all biomarkers. So in case there are any biomarkers which could tell us what are the chances of getting sperm, in the future it would be very helpful, and work is going on these and a lot of biomarkers. Now the second thing is that sperm per se, spermatogonial stem cells per se, can be preserved in different fashions. I've tried to bring out a slide to make it very simplified for everybody. So normally if you store a sperm, the stored or the frozen sperm could be used with ICSI. But if there are no sperms, what could you freeze? You could freeze the tissue. Tissue could be used as a transplant in a mouse to get sperms. You could do an organ culture and you could auto-transplant it. Or you could use cells, which could be spermatogonial stem cells, culture them to get sperms. Or you could in the future take a skin biopsy. In this pluripotent stem cell, you could get a sperm and use it. Now I'm going to tell you about the beautiful thing which has happened in the world. In 2011, Taihiko Ogawa, what he did was he took infertile non-obstructive azoospermia mice. They took out spermatogonial stem cells. In these spermatogonial stem cells, they cultured them, made sperms, used these sperms to inseminate mice, and had mice. And can you imagine a work like this done in 2011 may be done in humans as well, but they have not been able to do it till now. But in the future, this is one thing which could be done. CRISPR, we all know, is the magical thing of replacement so as to have normal embryos. But I will leave you with this last slide and the beauty of the way science is going on. Normally, a sperm and an oocyte make a baby. But if they're two men, at the moment what we do is we take a donor egg, दोनों आदमियों में से एक सिक्का उछालता है, कहता मेरा स्पर्म चलेगा, उसका स्पर्म लिया जाएगा in homosexual, or I would say in people of the single sex who have married or who are together. But in the future, a pluripotent stem cell could be taken, an oocyte could be made. With the sperm, you could have a baby. And if the two women, a pluripotent stem cell from one could be an oocyte. In the men, of course, a surrogate would be needed. But in the two women, one could give an oocyte, the other from the pluripotent stem cell could make a sperm, a baby could be made, and one of them could carry it. So this is the way the future probably is going to shape. But you realize one small thing that will happen. Two women can never have a baby boy. So I leave you there, and thank you very much. Thank you very much for inviting me, and thank you very much for being patient till the end of this whole program. Thank you.
Thank you so much, sir. It was very wonderful talk. Monica ma'am, you want to say something?
Yes, I think we are pretty speechless after
Yes.
listening to Dr. Sunil Jindal's deliberations. And
Yes.
anyone who has not understood can please watch the lecture again on YouTube. Rewind karke.
Yeah. Yeah,
Because you
and I think,
have so much.
Dr. Monica Sunil, Dr. Sunil Jindal is a star word of the male infertility. So directly anything that he can get from him. Yeah.
Thank you very much.
Jindal and Dr. Anshu are very dear friends. We have traveled half the world together. And apart from this, he's a very good singer, a very good shire, and he can make you laugh till your abdomen is ready to burst. So, Dr. Sunil, we are so honored to have you. And
Thank you very much.
we loved your lecture. It has given us a lot of, ideas and vision for the future. Studies on antioxidants, the work you have done with Dr. Ashok Agrawal, so many things, so many years of hard work you put in has been revealed through your talk. Thank you, sir.
Thank you very much. Thank you.
Yes. Thank you, sir. So now let's move forward for our panel discussion. I would like to hand over the session to our MOC, Dr. Manisha Jain, madam.
Thank you, dear Dr. Purnima, and thank you, Dr. Monica, for this very prestigious session. With this, we now move on to the next session, that is the panel discussion. And one thing that keeps perplexing us, all of the gynecologists day-to-day practice, is different scenarios, case scenarios of male infertility. And to moderate the session, today we have with us Dr. Venugopal M. Sir. Sir is the Secretary General of the Kerala Obstetrics Society, also the Secretary of the Kerala IFS chapter, convener of Andrology SIG IFS chapter, and consultant at ARMC IVF Fertility Center. I welcome you, sir. Next, I'd like to introduce all the panelists. I think we are very short of panelists who could join us today. First panelist is Dr. Akriti Gupta. Akriti Gupta is Secretary of Uttarakhand Chapter ISAR, and she's also the infertility specialist and IVF in charge, and Secretary of, and she's joint assistant editor of Yuva ISAR. She has a Yuva ISAR award at Yuva ISAR conferences, and I welcome Dr. Akriti Gupta. Next, we have with us Dr. Anupa Ravi Rutela. She is the founder and president of Rudrapur Obs-Gynae Society and considered at Futela Hospital, Rudrapur. She is executive member of National Foxy Endometriosis Committee. I welcome Dr. Anupa. Dr. Anushree, I think she is not able to join us. She there. Next, we have with us Dr. Archana Singh. Dr. Archana Singh is a very senior consultant, and she is currently the vice president of the Moradabad Obs-Gynae Society. She is holding different capacity and consultant at Naveen Hospital, Delhi. Welcome, Dr. Archana Singh. Dr. Radhika, I think also she is not able to join us.
No, ma'am. Ma'am is not joining.
Yeah. Dr. Shashi Bala, she is a very active and passionate gynecologist. She's been with us since yesterday. She's director and chief infertility consultant at Aveta Hospital, IVF, Patna. She received training and diploma in gynec oncology, cosmetic gynec and ART, and has been awarded with Dainik Bhaskar Jagriti Award and by none other than the Honorable Governor of Bihar, and awarded a Youth Icon Award of ISAR 2024 at Bhubaneswar. I welcome Dr. Shashi Bala. Next, we have with us Dr. Sonal Agrawal. She is again a past secretary of Mother Obsgynae Society and considered GR Hospital, Koshi Kalal. She has a special interest in water birth, labor analgesia, laparoscopy, gynec, and high-risk pregnancy. Welcome, Dr. Sonal Agrawal. Dr. Sonam also, I think she is not able to join us. Dr. Sonam,
Yeah, Dr. Sonal and Dr. Sonam, I'm not able to contact them. I'll contact again.
Dr. Sujata, she is secretary at Haridwar Obsgynae Society and considered at Ayura Clinic, Haridwar. She has served in as medical officer in Indian Army and was ex-SR at Army Hospital. Her special area of interest is high-risk pregnancy and infertility. I welcome Dr. Sujata. Next, we have with us Dr. Uday Sarkar. He is the honorary secretary of Siliguri Obsgynae Society. He is senior consultant at Siliguri and professor of Department of Obsgynae at MGM Medical College, Kishangarh, and has been the organizing secretary of East Zone Yuva Foxy. Welcome, Dr. Uday Sarkar. With this, now I move on to further proceedings to the moderator for the panel, Dr. Venugopal sir. Over to you, sir.
Thank you and good evening. I hope I'm audible. Yeah. So
Yes, sir,
yeah, I'll go ahead and first of all, big thank you to Monica ma'am and Ranjit sir for the opportunity to conduct this panel this evening. And as I can see from the here that we have a very interesting list of panelists. I saw Dr. Akriti, Dr. Anupama, Dr. Archana, Dr. Shashi Bala, and Dr. Udayan. I think that's my count correct. So
Yes,
I think we'll go ahead for a fine interactive session. I'll just share my screen. Our topic is mainly regarding like I always like to say this, demystifying male infertility, because male infertility remains always, some kind of a mysterious thing. We know a lot about polycystic ovaries, we know a lot about endometriosis, but when it comes to male infertility, we seem to know a little bit less than the others, even though the incidence of male infertility parallels that of the others. So I will just go ahead with our discussion today without wasting much time. Rather than, we learn a lot from our panelists and from their experiences. I'll start with seeking opinion from some of our panelists. I would like to know from our panelists their thoughts about this particular slide. That, over the years of experience that they have, do you find the sperm count to be decreasing? Does it frustrate you and your observations? We'll start with Dr. Akriti. Dr. Akriti, some observations from your side. Yeah. See, this is not a question and answer session. It's an experience sharing session. I want to be very clear about that. So all of you can unmute yourself and feel free to give your opinions, So what I asked is that, do you feel the male fertility is on the decline over the years? And what may be the possible reasons that you think is for that? We'll start with Dr. Akriti, your opinion. Yeah.
A very good evening, sir. And thank you to Monica ma'am. Yes, sir, for your this discussion about male infertility, yes, it is actually demystifying, because every time we join a lecture on male infertility, even Nagori sirs, even Sunil sirs, you get new points and you get to learn. So there's so much, and you think, okay, that was missed, and you get to learn, and then you add it to your practice. Yes. So as you said, yes, it is declining. Though my years of practice are quite less, but then still, out of evidence, I can say yes. In India also, if we have the evidence that says for the last decade, yes, 3 decades, from 40 million count, it has gone to 22 million, the total count for males. So yeah. So even the evidence says that, and yeah, in practice, yes, we observe the counts are declining, and it could be definitely because of the the practices which males are having currently, whether it is abuse of alcohol, smoking, tobacco, or is it stress factors, the job profile they are into, 9 to long time jobs. So many factors, as primarily environmental.
Our other panelists could also share their experiences. What's Dr. Udayan? What have you got to say?
I would like to add one thing.
Yes.
I would like to add one thing to what Dr. Akriti said.
recently because of the IT sector also, I think because males are more into these gadgets, mobile phones, laptops, and these might have an cause of declining sperm count or affect the sperm quality.
Yes.
That
So I
can be
think
a
Dr.
factor also.
Akruti mentioned stress. You were stressing about the use of mobile phones. Dr. Anupama, you were trying to pitch in with some opinions. Yeah.
Thank you, Dr. Venugopal, for having me here. And basically, a bigger thank you to Dr. Monica and Dr. Randeep for having me here. And I was surprised to see Dr. Venugopal. He's such a cute-looking young boy over there.
You got it wrong.
So that's heartening. And I'm very happy to say that I'm finding many new youngsters into this new field of the world. And you guys are doing a very, very good job. I just wanted to say one thing, that we don't need any more evidence to this statement than the fact that the WHO itself has changed its guidelines. So the things which we used to hear in our college days, 60% motile, 60 million, 60% motile, that was what we used to answer in our MBBS exams. And now it has changed to 15 or 16 million counts. So that is what evidence more do we need than to say that the male infertility is, the count number is actually decreasing?
Any other factor other than what they mentioned, do you feel contributes to decreasing sperm count, ma'am?
I feel it is mainly the pesticides, the excessive use of chemicals in our food chain, which is a very, very important thing.
Yes. Shashibala, ma'am, what would you have to say about these endocrine disrupting chemicals, use of plastics and these kind of things? Do you think they contribute?
Sir, it's a very relevant question, sir, present scenario, because we all see in our day-to-day practice that male infertility is increasing like anything.
Yes.
So, like plastics and environmental pollutants, to some extent, the unhealthy diet and lifestyle choices made by, our youngsters, they include different kind of drinks, like soft drinks, even cold drinks. They have, excessive amount of pesticides, undocumented anabolic steroid in some gym products. They all lead to disruption of the hormonal balance, and finally it lead to decrease in quality and quantity of sperm.
Yes.
There's one more thing which I wanted to add was that disturbed circadian rhythm is also one very important.
Sleep, yes, definitely, yes. I think that's a point to be made. Why I put this up is, just to bring out the relevance of our webinar today and why there's so much focus on male infertility. See, these are pictures taken from a few important channels, BBC and this thing. They call it Spermageddon. For those of you who don't know, just like Armageddon, Spermageddon. They say that, that one day, it's all going to be, you remember Jindal sir's last slide, you might need help from that direction. The sperms are going to be there and then the males are going to be extinct. So my next question to you automatically is, there's of course two opinions, okay? There's two opinions regarding this view. If you read up, you find that some people say that it's exaggerated, it's not the truth. Relatively, there's more research on male infertility and this thing. My next question is, what can males do according to you to, arrest this decline and to improve the counts and fertility? We'll start reverse order. Dr. Shashibala, what should males do better that they are not doing now that to improve this counts? Yeah.
So I think we have to do, as a clinician, responsible person of the society, we have to do some, awareness camps and education system, that how we can, protect the reproductive health of males.
Yes.
We have to, train them for having good diet, nutritious diet, plenty of water, regular exercises. They have to have good quantity of antioxidants in their diet. We should always emphasize them not to, use more of alcohol or smoking.
Yes.
They have to avoid, longer period of driving or, unnecessary use of laptops or cell phones. They must be avoiding to just improve this, sperm function.
Yes. So, we just try to play a little bit of helpers to this, many times young couples, forget, infertility patients, young couples do come to us and they ask us, certain tips like, okay, chalo, Dr. Ji, batao, what's about this diet, what's about lifestyle, and what's about weight and this coital practices. Do you have some specific advices or suggestions that you offer to the males? Especially, they'll want to know kaun sa khana, which food is better, which this thing is there. So let's say diet. Okay, let's take up diet. What are your secret diets for improving the count and this thing? Let's hear it so that some of our audience can derive something, that you patients. Yeah, Dr. Shashibala, yeah.
Sir, I always tell them to take Nimbu in their diet,
Nimbu is your favorite. Okay.
So that they will have natural vitamin C in their diet.
Okay.
They have to have, carotenoids and colored foods. They can
Correct.
include seasonal colored foods. I also tell them to use kacha lahasun, garlic. It's a good
Garlic,
source of
okay.
selenium.
Okay. Very practical, yeah. Okay.
They can use fish at least twice weekly. They can
Fish
use
is-
walnut if they're
Yes, fish is on
They
there.
can use green
Yes.
vegetables, spinach, broccoli. These all kind of fruits.
Anything that's
should
a
be
no
included.
from your side in the food? Your patients ask this, see, come on. Yeah.
Preservative. I always tell them not to use, processed food or
Yeah.
preservative containing food.
Dr. Uday, in your part of the country, what's your favorite diets for the meals to improve counts? You always have meals asking, don't you? Yeah.
Yeah. Diet is a integral part. They keep on asking. Now,
Yes.
what I tell them, at least, please do not gain weight, do not become obese.
Yes.
They should, obese people should cut down on calories.
Yes.
And as Dr. Shashibala was saying, having antioxidants in the diet naturally is
Yes.
most welcome.
So you don't have any favorite, like Madam talked
Fish.
about
No,
lasoon
no.
and all these things. Your favorites are not there much, huh?
No, not
No.
exactly, but having these in the diet, rasoon, garlic, and vitamin C, and ginger also for that matter. These do help, and fiber
Fine.
also.
Dr. Akriti, by and large, silent. What would you like to say? You can unmute. Yeah.
Yeah, sir, not primarily. I mean, I've never asked anybody to take lemon or so, but yeah, I think everybody has preferences. And yes, we ourselves would like to take lemon for a source of vitamin C, but primarily asking them to take, no preservative food. Just we ask for PCOS diets, avoid as much outside foods as possible. Take more of greens and, colorful fruits in the local season. So primarily this and good
Agreed.
water supplementation.
Yeah. What's it about this hatta gatta, little bit weight and all? It's good, no? Little bit chubby and all that. Dr. Anita, what's your thoughts about it? About males, why are we so much, not liking chubby males? Males who have a little bit of weight, they're very gentle. They speak nicely. What happens to the count? What's your thoughts, Dr. Anupama?
Hi. My favorite is the standard statement I always say is have some sprouts every day. So I tell this job to the wife, give sprouts to yourself as well as to your husband.
Yes.
And one thing I strongly always tell them is to avoid smoking, passive smoking as well.
Yes.
That is one standard advice.
Yes.
So, hookah is something which I have found very common in my part of the country in the youngsters. So
Yes.
that also I usually bring up.
No, I was putting the point on weight, weight and the male.
Okay.
Yeah.
Weight definitely, as we know that increased weight with a lot of estrogen conversions does happen. So definitely weight is always the primary thing. And
Agreed.
we usually give a target and send them to our dietitians. So
So now in our part of the country, I am from Kerala, and if they just ask, one peg. What do you have to say about that? Alcohol.
One occasional peg, I don't mind. They ask it, and I say that alcohol is not as bad as smoking is. So occasional drink. Today only one husband was asking me, in a month, madam, can I have 2 drinks? So I said that 2 drink is okay in a month.
Yes. What about all of you, Dr. Shashibala and Dr. Udayan? You people here in Kerala, invariably we have this question. They'll ask about this peg, and the husband and wife the wife will say it starts with 1. So index is 1, but then it goes. So what's your thoughts about it? Does it affect sperm count really?
I think alcohol is equally bad as well as smoking as far as sperm quality is concerned. So we should emphasize that if you are coming with subfertility, better to avoid alcohol until and unless your wife gets pregnant. And that's the best advice possible.
Yes. Dr. Shashibala, what's your thoughts? Or in your part, nobody's taking alcohol, or is it like?
No, sir. Actually, in Bihar, it is Like, but unofficially people are taking, and we always tell
Yeah.
them to have balance. Like,
Yes. Balance. And what's it
One,
about this? Yeah.
I
What's it?
just add something here, Dr.
Yeah,
Venugopal.
madam. Yeah.
I remember from my English class, I am an ICSC student, so we had very difficult English and lots of Shakespeare. So alcohol, it arouses the desire but takes away the performance.
Yes.
Yeah, so that I wanted to tell you. With alcohol, do you find that the patients will have erectile dysfunction, or in the long run,
Yes.
people who are taking 1 peg daily or 2 pegs daily?
Yeah, then generally we tell them, yeah, to avoid. But then what happens is you have to be very balanced in your opinions, because next day, we here find the patient won't come back to you. And then, because it's so much ingrained into the society, so you have to be very delicate about it, but you have to be aware. And we have a problem here, They'll say, I don't take alcohol daily. It's only, when there are festivals that I take alcohol. No, you ask the wife and she'll talk about binge drinking, which is supposed to be equally bad, these sort of things. So you have to just get into fine. And like you said, alcohol too much definitely affects sexual performance. There's no doubt about it. So I think a discussion is warranted. What about the females?
Nowadays, I see couples where the husband and wife are drinking together.
So what's the advice?
The drinking in females is growing so much.
Yes. Yeah.
That, yeah.
Dr.
Earlier,
Akriti, you're nodding your head, but you're on mute. What are your thoughts about it?
Sir, I'm a teetotaler though, but then I've seen patients. Yes, I actually ask. I see the, actually the profession they are from.
Yes.
Not asking these questions to conservative background families, but yes, if I see somebody from an IT background and if I see somebody from an educational background, I particularly ask the question to the wife as well.
Yes.
And they are not at all hesitant answering. They are taking it or they're not taking it, and they take it as a normal question to them.
Correct. So I think these are all the points you have to ask. And coital practices, do we regularly, I think everybody should opine, do we make it a point to ask? Because you do find a lot of sexual dysfunction nowadays, no? So it's not only about healthy coital, means sex, but also, sexual dysfunction. Do you, all of you are broaching into the topic, and how open do you find these patients with regard to this? And after this COVID and all these things, do you find increase, especially stress and all this, the sexual dysfunction has increased? Do you feel like that, Dr. Udayan?
Now, once you ask a direct question, they open up. The couples do open up. Yes, occasionally sexual dysfunction is a part of the problem.
Yes.
But I have found couples, who do not, basically new couples who do not know the timing part also.
Yes.
The fertile part. So
Yeah,
these
very
counseling,
basic things.
very basic things.
Yeah, we're thinking about big things, but these are big things. Patients don't know still about fertile this thing. They may know about positions, but they'll never know about the fertile days and all these things. It's the influence of our modern communication, our TV channels and all these things. So these are all things. Then what about mobiles? I just wanted somebody to just touch upon mobiles. I think some talk was there, earlier talks also, there was this thing about mobiles. What do you advise your patients regarding? They ask you, about mobile phones. What's your thoughts about it, Dr. Shashibala?
So I always tell them to just keep their mobile preferably on silent mode, away from their bedroom always, because it will not only it may disturb their sleep cycle, apart from this electromagnetic radiation.
Yes, so the sleep cycle is important. This thing, electromagnetic radiation. So, mobile phone to be kept in pant pocket or shirt pocket, Dr. Anupama?
Well, mobile is near the pant pocket is also not good, and shirt pocket is also not good.
Yeah.
Either things are not good.
Yes.
And especially at night, I have seen actually one of my patients, I've kept her embryos, and I've told that lady to lose her weight before I put back the embryos. And last month, I found out that the couple is separated.
Yeah.
And when I digged into it, though, we realized that mobile was the culprit.
Yeah, absolutely.
Because
I think we have to address that problem. And there are the electromagnetic fields, the earlier topics that one of the speakers was speaking about EMF or electromagnetic fields, especially keeping it in the pant pocket is bad, is what they seem to stress more. But when you keep it in the shirt pocket, maybe the cardiologist will be a little bit more worried about it. But, like you said, it's better to keep it at a hand's away distance from from where you are. But we have to talk all these things to the patients. That's the point that,
basically, I feel that whenever we are doing scans and we find vaginismus in the female, she's not lying, I usually find that erectile dysfunctions are starting from there only. It is very, very common to have erectile dysfunctions in a male whose wife is having vaginismus.
Somebody mentioned that patients come out with erectile dysfunction, but many times it is only when you do the scan that you discover, the female is very often reluctant to say that there's a problem like this. And that's a very good point that I think Dr. Anupama has brought out, that, it's only when you do this, many times, unless you broach the topic, you're keeping on asking the questions again, you don't come out with this history. We have seen patients who had, IVF done, but never had intercourse even once. So I will come to that question, that thing later. So just to emphasize before going, about this food, this weight and all these things, we didn't want to get stuck up there. The next point from our view of all the practitioners is, that, do you find in your area of practice the evaluation of the male to be satisfactory, and what tips do you have to give to your gynecology colleagues? All of you here, I can see on our panel, are doing infertility practice, but what more do you wish that your gynecology colleagues, gynecologists, they would have done a little bit more? Do you find evaluation of the male to be optimal? We'll start with Dr. Udayan. Yeah.
First of all, I am not a infertility specialist.
Okay.
But I do get infertile couples.
Yes.
And this is one area. I get a lot of patients who are infertile and who have been treated elsewhere.
Yes.
But I frequently do not find the husband semen analysis with them when they come to me.
Okay.
All sorts of investigations have been done on the female.
Even before going there, I want to ask Dr. Anupama, Dr. Shashibala, and Dr. Akriti, how many of you do examine the male partner? Examine the male part.
If I suspect, then we have a male doctor in our premises, MBBS doctor. I think in 2 months I'm sending one person. I think somebody else is there on unmute.
That's okay. Yeah.
Sorry, ma'am. वो मेरी daughter आ गई थी. Sorry.
Yeah. No, that's okay. Yeah.
So it's not very frequent that I am doing it myself.
You have a male MBBS doctor to do the things if you feel necessary. What about Dr. Shashibala?
Sir, to be honest, I myself don't examine, but
You don't
sometimes
examine.
if
Dr.
I
Akriti?
yes,
Sir, I do the semen analysis and I ask the history, like you said, coital frequency and all those
So,
questions. of which
Dr.
I-
Monica, madam, since you are here now, I would like to ask you, just for this thing, what do you have to say about that, this particular thing? So we had 3 infertility specialists who are, either having somebody else doing the examination of the male, or why does that happen, and what's your thoughts about it?
So because the conservative background in the country, nobody in a male,
It's not that. It's not the conservative thing. I'm myself doing the TISA for those patients.
Yes.
Yeah, sir.
When I'm doing the TISA, I can do the examination.
TISA I'm
The
also
husband is and the wife is not comfortable getting it done by me, and they are rather comfortable doing it.
TISA is in the OT. आप फिर भी थोड़ा सा, you keep that blind. You have few people
Patient
around
is
you.
under anesthesia. Yeah.
So what I would ask is,
local. That is there. But in examining in person, it is similar like, surgery mein when we used to do hernia examination, we used to have a case. It was very difficult for us to examine the male.
See, in our part of the world, it's still the male gynecologists are not so common. So, of course, the female andrologist would also not be so common.
No, but wouldn't we miss out on many of the things? That's my thoughts, Dr.
No, as we say that, male thing, investigation is more important than history and examination. Your semen analysis report tells us quite a lot. The postcoital test tells us quite a lot. And if required, then we do have help like ultrasounds and physical evaluation by someone else.
So you don't regret not examining every male?
Yes, I do not.
We have even we have a urologist. If we have an andrologist with us, definitely they can examine. And
Sir, I would
we
like
definitely trust them.
Yeah.
So actually, So
Can I say
actually, I'm having luxury of having urologist, like my husband is urologist. So that's because of all that also I avoid.
Okay, you're a
Actually,
lucky one. Yeah.
that is the luxury we have, when like suppose Randhir is there.
Yeah.
Yesterday there was a patient in whom I felt testicular volume assessment is very, very necessary.
Yes.
And I mean, it was just convenient that Randhir did it,
Yes.
So here also in MP, sometimes like if I volunteer to do the testicular examination, though it's very easy to do,
Yes.
then probably there would be some sort of, hesitation from the couple. So if you have an alternative, it works. But if you don't have an alternative, then proper counseling and in the presence of the wife, I think you can do the examination. That's the
You
future.
should. I think we miss out on a lot of things. We miss out on a lot on.
What about Kerala, Dr. Venugopal? Like, do female gynecologists examine the male?
Yes, they do. They do. They do. But the irony in Kerala is many of the infertility specialists are males. But they do. In Kerala is a little bit more open. I can fully understand the sensitivities in different parts of the country. But the point to be made was that, when we say the male deserves better, examination is on the agenda. You miss undescended testes, you miss very small size testes, you miss, things like hypospadias, which is responsible. A lot of things, you miss, and you miss surprisingly things like hydrocele, all these things are missed. Even small, fungal dermatitis on the skin of the scrotum. All these things contribute to male factor infertility. You do miss a lot of things. Dr. Udayan, are you coming to my defense or are you preferring?
Yes, definitely. I wanted to add something, Dr. Venugopal. The males basically are a neglected lot.
That's the point. Yes.
When the infertility is concerned, because even if you are not an infertility specialist, a lot of couples do come to the gynecologist initially.
Yes.
And once the gynecologist finds that there is a male factor, either the gynecologist sends the male to the urologist or he or she sends the couple to the infertility expert.
And to be understood is when you send to the urologist, for the urologist, a male infertility patient is the least lucrative one. They have a lot of better other things to do. They have a renal stone to take care of. They have a lot of other things to do. Unless, it's husband and wife. Yes.
Exactly. And practically what happens, I have seen in male infertility, they end up having ICSI or whatever.
Yes.
Instead of a proper treatment.
Yes,
that is the practical part.
That's the thing. Yeah. Well, then another basic question about semen analysis. You have a lot of semen analysis done in many labs. Around the area in which you practice, how do you benchmark a few semen analysis reports? Because we all said semen analysis is very important, WHO criteria, all these things. I want to know a very practical thing for listening gynecologists, that how do you look at a semen analysis report and say, "Acha, this is a good one," or this one I should do it again. What's your thoughts about it? We'll start
by looking at the morphology.
That's one
thing.
Yes.
Which tells us that the person has sincerely done it or not.
Yes. Very, very important. How about Dr. Shashibala? How do you do? What's your this thing? How many labs around your practicing place do you believe? Because patients will have 100 semen analysis reports with them. How do you benchmark semen analysis? That's very important. Now, Dr. Anupama looks at the morphology.
It's morphology for me, sir. And then, I will also rely on morphology itself.
Yeah.
That's very true. Because majority of them have only two parameters given, the number and the motility. And morphology is almost 90% missing. It's never there.
Correct. And then
if it is there, they will not follow strict criteria, sir.
Yes.
Usually they will not 70-80% normal morphology.
When the moment you see morphology 70-80%, there's something wrong with this. So these are a few tips, and when you have to look for things other than the count. That's where it is. It's not the.
And one more thing, sir, abstinence period. Many times they don't ask the couple, like if it's a lab. So they're simply like day before yesterday, one patient had come with a report of severe oligo, and I just saw the abstinence period to be 30 days. I said, this report, and and then we did a normal semen analysis at correct abstinence time, and it came out to be normal. So the patient was surprised to us, and then they asked me, why have we got this? And we got these 3 months medicines from there. now you have not given us any
So
medicines. And
point
you're like,
to be
okay, because
made
of this.
Yeah, point to be made for the gynecologist colleagues is you have to benchmark a few labs around the place where you practice. And to benchmark, you have to look beyond the count. There are clues that you get beyond the count where you realize that it is a good lab or there is not a good lab, no? Because many a times the male doesn't even accompany the female partner and you have to rely on the old reports. That's the thing that I was, trying to emphasize, that you expect a good semen analysis report, because from what discussion we had, what is that mainly it's the semen analysis report that's on the basis of which the male is being treated. So even if that's not being done well, then that's very, ironical. Now, the next point or the things which we are going to discuss is just a few clinical situations, okay, that we get in our daily practice. Now, one is an issue of, like, we are speaking about erectile dysfunction. I want to know that as all of you, what is the routine medicine that you are giving? How do you deal with erectile dysfunction? Like, if a male tells he's erectile dysfunction, please don't say that now that you're referring to a urologist. That's not the right thing to do. How do you go about doing it? We'll start with Dr. Anupama and then we'll come to Dr. Shashibala. Yeah.
Hi, the first thing which I would ask about this erectile dysfunction is that for how long has this been? Since it's from the day one of the marriage, or it's been later?
Yeah.
I would also bring up a question of, is he able to masturbate and produce easily or not, the semen sample?
Yes.
So in this situation, like where the husband is diabetic, I would also want to know how long his diabetes has been.
Correct.
And what his present HbA1c is.
Correct.
And all that
A
would
little bit beyond just erectile dysfunction, no? Because we very often we have to investigate as to find out as to whether it's there right from the beginning. If there's diabetes, Dr. Shashibala, anything you want to add? A little bit beyond just giving Viagra or sildenafil. That's the point we need to make. What's your approach?
So we have to work upon the exact cause of this erectile dysfunction.
Yes.
And for this, a detailed history taking and very supportive counseling is mandatory. Then only the male partner may be able to open.
Discuss, try and find out, and then when you offer
in 80%, yes, sir, in 80% cases, it is actually psychogenic. We have to give proper timing.
Correct.
And supportive counseling will help.
And if it's medicine, what's the medicine of choice that you're giving?
Dura Plus, sir. It contains tadalafil and I think dexapeptyl, sir.
Okay, so you're giving that group of drugs. Anything
Dura
else?
Plus, yes.
Yeah. Do all patients respond to that?
Sir, generally, yes, sir.
Either
Yes,
they
it is
respond to your treatment or they'll go to someone else. That's what usually happens. That's the point I want to make. Dr. Anupama, what's your approach? You are asking history, nice, and then after that, in form of treatment, directly we don't send them away, do we? So what's your favorite medicine of choice?
I usually prescribe them tadalafil along with a lubricant jelly.
Yes.
And if the thing doesn't work, then I send them to our psychiatrist friend.
Yeah, you send them to a psychiatrist, right? So what dose, Dr. Akriti, what dose are you giving? Low dose medicines, or do you start with the full dose of 50 mg directly? How is your
No, sir. Sir, low dose, and also it depends upon the weight of the patient as well. But yeah, low dose would be preferred.
Yes, low dose, no? Low dose means how much and what's
Sir,
the
25, and I have usually given sildenafil. So I have not practiced the use of tadalafil.
No, why low dose tadalafil is very well established, no? See, what happens is when you give it in a low dose, say for example 5 mg or this thing, what they say is the tone of the the vascularity and the tone increases and it gives confidence to the patient.
Okay.
And that's how they benefit from it. That's how you ask any urologist or sexual medicine people, they'll always start with a low dose, small dose, and then they'll keep on increasing it. That's the point that
So are there any differences between use of tadalafil and sildenafil? Because even if I am using sildenafil in practice, that also works,
it works wonderfully.
well.
Yeah, it works wonderfully. It's only related to the half-life and this thing. Okay. Similarly for IUI, see, a patient has come, all of you are fertility specialists. If a patient has difficulty in collecting semen, my question to you would be simply that what solutions you have and what precautions you take. What's your very practical solution? No? Sometimes
many times, sir, many times.
For IUI, or let's forget IUI, even to give a semen sample.
Semen sample only.
Yeah,
correct.
what do? You give the same thing. Huh?
No, sir. If in case that happens, and it is the problem of, the same question that ma'am asked, whether it is happening, at the time of intercourse or otherwise also it's happening. If it's only happening and the patient is able to ejaculate, so
Correct.
we can ask them, maybe it's the anxiety of the hospital. So if they want to have a home collection, we can give
That's the
them the
point.
advice.
Yeah, that's the point. Home collection, say for example, patient came for IUI or this thing. Do you allow it in your routine practice? And if you allow, what precautions do you take?
So
Dr.
definitely, because we have seen many times the patient has, anxiety at the point of collection, and many times the wife will tell us 2-3 days prior before the IUI that ma'am, he has collection problem, he has anxiety. So, please advise home collection. So the couple is aware of that problem, and we counsel. Our embryologist will tell them, the andrologist will tell them that how to have a sample collection, ideal situation, and in how much time it has to be there. In 30 minutes, it should be there with us. What all precautions to be taken, and it is equally
Dr.
effective.
Shashibala,
It
in
works.
your
It works.
in your clinic, Dr. Shashibala, what little few steps you have
Sir,
taken to
yes,
have a
if they are
separate
having,
room?
yes, sir. If the male partner is having anxiety in hospital premises, we allow them home collection, but we always take consent that this semen sample has been collected
And in
from.
your hospital, do you have a separate room for semen collection?
Yes, sir. Yes, sir.
Yeah, you do have a
Yes, sir.
separate,
With attached lavatory, we are having, sir.
yes, you have attached this thing, and do you have some kind of literature there and things like that? Do you do these basic things, to aid
This
semen
is
collection?
what I wanted to bring up, that
Yes.
usually you should have a separate room, and along with the room, I try to send, whenever I find that there is a problem, I usually try to send the wife along with the husband.
Yeah,
and
very
then
important.
and the wife would help.
Yeah. Dr. Udayan, anything do you want to add?
No, what I want to add, if it is a home collection, they should take the sample to the laboratory within the requisite time.
Yes, very important.
Maximum,
Another point.
the
Yeah.
time is very important. Within half an hour, at least within
Correct.
15 minutes to half an hour, they should reach the sample to the laboratory.
Correct. Very important, no? And then how to collect, and then sometimes the patient will tell we'll have intercourse, and at that time we'll collect. That thing should be generally avoided, no? That's a point.
Yes, exactly.
Yeah. These are all very practical things that is there. See, now this point Dr. Anupama was maintaining, that, many people, they come and say that the marriage is non-consummated, but the husband will come and tell you that masturbation is okay, but I have this situational problem. That is, only when it comes to my wife, then I have a problem with having intercourse. Then what's your advice, Dr. Shashibala? Our advice cannot be silence. So how do you approach it?
So we have to counsel the male partner that he should, have some talk with the wife and be comfortable with the situation, and then he can,
this
try.
is one key.
I would rather be counseling the wife more than husband.
Yes, madam, just please give me, counseling the wife. Wife is already very angry because telling this, some doctors already done a hymenectomy saying that it's a problem. But now it has been recently discovered that the problem is with the male. So what's your what's your thoughts about it? You do get these cases often, and these cases you get only if you ask about it. That's a point that I wanted to make. And counseling is very important in these cases. We won't go into detail about this situation, but it's different from the other situations. See, erectile dysfunction is 10 to 15% only. Psychogenic causes are almost 52%, and sexual habits of the male should be asked. All these things are very important in approach to this kind of patients. Okay, situational anejaculation, it is called. That's the thing. Now we'll move away from there, but again, these are common day-to-day situations. Now we'll come across this. That, we came to morphology, and again here, a male patient has got this report saying that all sperms are abnormal, and they've come to you in search for solutions. Very sad and very upset. What are your thoughts about it? We'll start with Dr. Anupama. Yeah.
So,
how do you approach a patient who has been counseled that the problem is an abnormality in the morphology?
Well, we look at the report, and mostly when the sperm morphology is written something like 6 or 7%, many of the gynecologist friends would still say that it is something abnormal, whereas we know that with the standard good reports up till 4%, it is absolutely okay to have 4% normal morphology. So that is what we will wipe his tears with.
Yes, you have to wipe his tears because, for a male, it's an awesome, no, not awesome, sorry, awful feeling that, to be told that all your sperms are looking like 2 heads and 4 tails and all these things. They feel very bad about it. They want to know, will I have a child? Dr. Shashibala, what are your thoughts about it? Morphological abnormalities, do they all need treatment like IUI, IVF, or can they conceive even without? Or do you look differently at some abnormalities than from the others? A few points just for the audience.
Yes, sir.
Yeah.
So,
Yeah.
yes, sir. If abnormalities can be in head, tail, or mid-piece, so we have to just look for the etiology why this abnormal morphology is there. If it is correctable, we can go for that. And if it's a case of like global zoospermia, in that
Yes.
case,
Yes.
in that case, we have to counsel the couple that they will need ICSI, and even ICSI may fail in some
If the
cases.
point to be made is that the study of the abnormality should be made. If it's a generalized abnormality, or if all the sperms are, for example, globospermic, then the outcome becomes a little bit different, no? Otherwise,
Yes.
not all these patients need your, ICSI and this kind of things. So that's the approach. And definitely, even with complete, very bad morphology also, there are a lot of reports which say that, see, we said that finding out the cause is important, but it's important to understand also that many a times we don't find out the cause. What's your thoughts about it, Dr. Anupama? What are do you agree or disagree? Like, how do you look at sperm abnormalities?
So many times we do not find the cause, and if it's really not working, then we move ahead with other ART procedures.
Right.
I must say, Dr. Venugopal, and I must congratulate Dr. Monica and Randir that you have selected a very right moderator, and you are bringing out things in a very friendly, happy way. This is such a good moderation, Venugopal.
You know what, Dr. Venugopal, I wanted you to ask one question which you asked us in Mumbai.
Yes.
You asked us which patients to give CC, which patients to
Yeah,
give.
I didn't put that on these slides, madam, because the entire topic was dealt with by Sir, no? That's why I did not overlap of
I felt
topics.
that
such a
particular
relevant
slide was very good. That particular slide which you
we'll
told
just
us.
run through this and then I'll come back to that
Yeah,
one.
please just speak 1 or 2 minutes on that slide.
We'll
also.
take that also. So this is regarding the morphology. Anything, Dr. Udayan, you are very silent, and Dr. Akriti also, I'm missing her now. Where is she? She's off and on.
Someone on the door, she says.
Dr. Udayan, what's your thoughts? Any things that you want to say?
Since it's very difficult to find the reason.
Yes.
It's very important that we take a proper history.
Yeah.
And do away with whatever problems the male has, like alcohol, smoking, etc. But if the problem is really global, I mean,
yes,
that means
globozoospermia and those kind of problems they require specialists. See, for a gynecologist,
it requires a specialist.
Exactly. And then like we were discussing earlier, it's not about 60 or 80% morphology, it's just 4%. This is the thing we need to counsel the patients, this 2%. It's just 4%. Don't be disillusioned by this things. We'll just, that's the message conveyed. Next is we coming to this very important thing that about leukocytospermia. See, we touched about it in one of the earlier things that, a lot of these leukocytes are seen, non-spermatozoa cells. Dr. Shashibala, many times we find that in our semen analysis reports, 10 to 15 pus cells per high power field, 15 to 20, and report after report after report of patients have this. How do you approach this particular problem? Just tips, practically.
Okay, sir. So whenever we face this leukocytospermia, we just try to find out the cause, like whether it is associated with, some prostatitis or seminal vasculitis or any sort of infection, or any, we have to also differentiate that whether they are immature, immature sperms or round cells, and accordingly we can give them antibiotic after
Now you must tell me the truth. How many times in your lab have you tried to differentiate whether it is a germ cell or it is a leukocyte?
So being honest, till now I have not personally.
Have you ever done it?
No, no, sir.
Yes.
No, sir. No, sir.
I just know about the myeloperoxidase test, but I have not
Akriti is
ever
back.
done.
Yeah, Akriti is back. Come on. Yeah. Have you ever differentiated in your years of practice whether it's a leukocyte or it's a germ cell?
No, sir.
I
Yeah, Dr. Anupama, have you?
Yes. We have tried
What's
doing
the stain you're using? You're using peroxidase.
Peroxidase.
That's a
The
big,
brown thing which comes
yeah.
up is
Yes,
the.
that's a big shout out to you. I think everybody should take the message that there's a way to differentiate, and we should go a little bit out of our way and try to differentiate. Why is because this leukocytospermia is one of the biggest reasons why abuse of antibiotics in male infertility. It's very important to understand. Dr. Udayan,
Sir, can I add a point? Like
Yeah,
we
you
in
should.
routine, like we do the semen analysis, we also
Yeah.
do routine, semen culture.
Correct. You are
So-
doing routine semen culture?
Yes, sir.
Huh? So,
Yes, sir.
anybody wants to have any thoughts
So
about
if
Udayan?
in case, many times what happens when we explain the full technique to the patient,
Yes.
how to do it, because since we have a separate area for the
Yeah.
collection and everything, and we properly explain the patient, this is to be done, this is not to be done.
Hmm.
And beyond that, we also check it with the lab, whether, because they give it in, provisional report, then they give after 48 hours as well.
Yeah.
So, is there any role, like suppose if there's no leukocytospermia as well, but still sometimes the cultures are positive. And then second, like leukocytospermia, as ma'am said, you differentiated it from round cells. And if we don't do that, so does that then culture help you?
See, what you said you do routine culture. Now you must also tell me what happens and what reports you get on routine culture.
So we get, it's not that we get negative reports or positive.
No, you do get. Many a times is leukocytospermia.
Okay.
You do get this is culture. There's something called culture negative.
Mostly sterile. Mostly sterile reports are
yeah.
obtained. You do
There
Yeah,
is a-
mostly
Can I add
it's
something?
sterile only.
Yes,
But
yes.
just my question was that if in case, like ma'am said, we're not differentiating, suppose,
Yeah.
and that time we get sterile reports. So definitely we don't give antibiotics.
You can combine your antibiotic with an anti-inflammatory and those kind of medicines. I'm coming there.
Okay.
So why I'm asking you is when do you decide whether to give antibiotics to these patients or not? So are you giving empirical medicines? Are you
No,
giving
no, only
Because
culture
I'm- I'm-
positive,
do
and
you use-
sensitivity is also there, sir. They have sensitivity also, culture sensitivity.
Do you use, Shashibala madam, do you use empirical antibiotics?
I would not say it's empirical. I ask patient about the symptoms. Also, I
Yeah.
look for the motility.
Yeah.
And some suspicion about the existing infection. In those cases, I add antibiotic. Or if the patient is having a history of IVF failures or embryo, bad quality of embryo, in those cases I suspect high DFI, and in those cases I add
So
antibiotics.
see, what is to be done is on this slide. Okay, what is to be done is on this slide. Low level leukocytospermia could be given an empirical dose of doxycycline or azithromycin. Low level leukocytospermia. Culture negative patients is what Akriti was talking about. With proven leukocytospermia should be treated with anti-inflammatory.
I feel that many a time.
Who is somebody's thing is breaking. Are you
I
able
feel
to?
that culture test.
Yes.
Am I audible?
Yeah.
Yeah,
Dr.
Akriti is actually, I think, mobile. That's why sometimes her voice
Yeah,
is.
she's getting this thing. Anybody wants to, Dr. Anupama, do you want to make a point? Yeah.
Am I audible?
Yes, you are.
Yes. I wanted to say something.
Yeah.
That semen culture, I feel sometimes it comes positive, whereas actually the infection is not there, and we should be very particular that this is something to be really told to the patient specifically, that the culture sample should exactly go into the container and not be a contaminant. This is the commonest problem. I have seen
Most
so many
common.
culture positives.
Most
and
common. I agree fully with you. Many a times what happens is improper method of semen collection. Many a times uncircumcised males, they have this preputial foreskin. There will be a lot of contamination in that. And then the semen sample will have a lot of contamination. This is another important thing. The improper method of semen collection should be described to the patient in these cases. It's very important to have these sort of things, because don't just randomly prescribe antibiotics. At least, tomorrow onwards when we practice, you should have it in a thought. Think about peroxidase stain. It's available. If you search for it, it is available. Try and make a small attempt at differentiating between pus cells and this thing. These are all very important things. And because see, even if you give, many a times there is what is called as MAGI or male accessory gland infections. Prostate doesn't have very good blood supply. All your antibiotics don't reach the prostate fast. Even if you're giving antibiotics, you got to give it for a prolonged duration or a longer duration of time. These are all important things. Don't give for 5 to 10 days and then stop it. Okay, so I think these are points which we need to take across, because the males would have had antibiotic after antibiotic. Dr. Shashibala, you want to make a point? I think your
Sir, I
hand.
wanted to know about the cost of this peroxidase test or.
No, the is available at a very reasonable. We have located near our lab. There's a place from where you get scientific something. And similarly, in your state or where you practice nearby, where you get these reagents, there you do get peroxidase. It's not very expensive. No, it's only that many people don't use it. So you'll have to tell them this is for this, and you'll get it. Please.
Sir, I will
So I
try.
think that effort should be made. Now, there's just this simple thing of, a situation. We are discussing situations. This situation where, a father has come with a son, married 2 years, advised chemotherapy. So they want to know fertility preservation options. I want to know from you, people, how many of you are offering this to your patients?
100%. Now this new rule has also come up.
Lovely. Yes.
New ART Act, and
Dr.
there is a
Shashibala,
specific form for that.
Are you also
Yes,
offering?
yes, sir. Yes, sir.
You are offering, no? So
Yes,
what
sir.
are these questions that when you store semen sample, will
So
the
even
semen
for
have-
minor also we can get the sample frozen, even for the minors.
Yes, very important. Dr. Udayan, are you also offering it in your clinic?
Yes, I'm not. Once again, let me say I'm not an infertility expert, but it's routinely done here. Routinely done.
Routinely done. Yes, these are
Yes,
things
yes,
that
yes.
we should have routinely. So how many samples, Dr. Anupama says, suppose if somebody is referring a patient to you, what's your how many samples do you usually preserve? And patient would ask you that for how long can these samples be kept? Dr. Akriti?
So the sample can be preserved for 10 years, definitely. And it depends upon the vials that we get. So minimum, we take 3 to 4 vials we preserve.
Yeah, no? And this question, yeah. Yes, anybody wants to add something? Yeah, I'm just... this happened, to one of our patients. What are your thoughts about it? What happened was, unfortunately, the person who had frozen his sperm, the person expired. And then the wife came and said that you had frozen my sperms, husband's sperms. Now I want to use it in my husband's memory. I want to have a child. What are your thoughts? See, these are social parts, these are all situations that one day you may face. So you should be prepared to deal with it. That's why I put it. Dr. Shashibala, what's your thoughts about
Yes, sir. When we are freezing this semen or gamete, there is a form number 10 is there. If I am correct, form number 10 is there.
Yeah.
In that form, this option is there for both for wife and husband.
Yes.
Whether after their death, this has to be handed over to the their spouses, or it is to be handed over to the government for research purposes.
Correct.
So,
So posthumous reproduction it is called, and then it requires prior consent, no? So this is the thing important. You can't just do according to how you wish. You should remember there are new ART laws and regulations, and we should be abiding them. That's the point to be made. This happened. So I thought I'll put it in today's slide. That's it. Just for the knowledge of people who are listening. Anyway, Dr. Anupama, do you want to say something?
I wanted to ask, is there any guideline as to how many number of samples should be kept?
No, there isn't, but minimum, I think you keep 2 at least.
3 samples at least.
Depending upon how many the patient can produce, because patient is going for this thing. Now, the next point, practical scenario, when do you operate on varicoceles? I would just, your 3 or 4 thoughts about the varicocele. I'm not interfering. I just want...
I have to say something. I feel that this is a overtly hyped thing, and varicocele, unless until it is without coughing also, it is very obvious varicocele. That is the only varicocele which is of concern. Otherwise, something which is ignited only once the patient is made to cough or something, that is not increased vascularity in the pampaniform plexus, and no extra heat is there. And it doesn't really make any...
So I want to ask you, when you don't have a look at the patient, then how do you recognize an operable or an inoperable varicocele?
So this is a very nasty...
No, it's a very relevant question arising out of discussion. I'm asking you that when you don't see the patient and when an MBBS doctor is seeing your patient, or maybe when somebody else is seeing your patient,
Yes.
how do you decide that varicocele is
So I'll refer it to a surgeon who would decide for that.
But
After all,
when? How do
varicocele
you
is,
know?
a surgeon is
No,
going to operate.
I'm not referred to a surgeon. I will take a call. I
Huh.
will take I
Yes.
will take the opinion of a surgeon, but if
Yeah.
it is operable, I will send to the surgeon, but I will decide whether it has to be operated or it has not to be operated.
Okay. Okay, I'll give it to you, but you were stumped at the question, no? That, how you're dealing with it without seeing. Do you find it to be useful in any group of patients?
So yes, in case you have severe, the third grade varicocele, or if you have severe oats also, then also there are so many studies to support, and we have seen it in clinical practice also. If varicocele is operated, even patients have azoospermia, they even tell you before doing TISA, it should be done, so that increase the
Yeah.
risk of DNA damage is there. So that also happens.
Yes, there is a role, but the role is limited and the role is very defined. Don't, just because you see a varicocele, we shouldn't operate. That should be the message, no? So I put up a slide there. Do you agree with all components of what's written on the slide?
Moderate oats, they say, with the normal testicular size and FSH levels. Yeah, perfect. Venugopal, you are unmute. You have to unmute. Yeah.
The last slide I wanted to put up after this was a patient who's been diagnosed with azoospermia. So once you see a semen analysis of azoospermia, I wanted to know what next in your scheme of things. Dr. Shashibala.
Sir, we actually, I used to refer it to, my husband, but the protocol I would like to share. We go for hormonal evaluation. Apart from history taking physical examination, we go for hormonal evaluation, which will include FSH, LH, testosterone, E2, and sometimes even prolactin.
No,
We
I
also
wanted
count.
to ask you that when you see a report of azoospermia, what is the first thing you do in your lab?
Repeat sample.
We repeat the sample
Yes.
once. We
First
need
of
at
all,
least
I
2
have to
reports.
see if sample is from our clinic, I'm sure that it's azoospermia, because before documenting that report, all precautions have been taken place. Then only we release the report, sir.
No,
Whatever
you
does that.
that is all very good. But there's one point I want you to highlight in this discussion, that what should you do to that sample before diagnosing it as azoospermia? Anybody can take the call.
We have to
Centrifuge.
centrifuge
Yes, that's the point.
at
Yes,
300
yes,
RPM for 15 minutes.
yes.
We routinely do it, sir, in our setup.
Yeah, no, you do centrifugation. And what is that condition called? Where after centrifugation, when you get the...
We have to examine the pellets.
अरे कोई तो बताओ उसका नाम क्या है वो
Cryptozoospermia.
yes, that's what. That's just to make the gynecologist aware that there's an entity called cryptozoospermia, and almost 16 to 20% of azoospermia cases you find cryptozoospermia, and then the outcome and the output is totally different. Next question is, does azoospermia mean donor gametes? Udayan sir?
No, not at all.
Not at all. That's the message we give, no? Yes. What percentage?
Dr. Venu, your slides are not moving.
Yeah, it's not moving. I saw that. I don't know what to do about it. But anyways, we'll continue the discussion. Yeah.
Yeah, it's moving now.
It's moving now. Yeah, I didn't come there. I came to azoospermia, but I had one more slide. I don't know what's happening, why the slides are not moving. But anyways, yeah. This was the azoospermia thing I was asking about. And yeah, it does not mean donor thing. So how do you, what percentage? And do you think the output for azoospermia has become better nowadays?
Yes,
Yes,
definitely.
sir.
Actually depends whether it's non-obstructive or obstructive.
Yes.
Basically, the
Very
management
good.
also differs.
So we make a small attempt just to detect whether it's obstructive or non-obstructive, because it makes a huge difference in outcome. That's only gynecologists ko utna hi malum. The gynecologists need to know only that part of it, that there's something called obstructive and there's something called a non-obstructive. Obstructive has very good outcomes. So azoospermia does not at any point of time mean donor gametes. The previous slide I had put about other than azoospermia was about thyroid and prolactin levels. How important are they in male infertility? Yeah, anybody's call. Yes.
Hyperprolactinemia means altered production of the hormones. The GnRH would not be there the way it should be. So
The FSH-LH suppression.
Correct. FSH-LH suppression. But is there any clue in which you think about prolactin? You don't routinely do prolactin, no? So which situation we do prolactin? The libido is a giveaway. If a male tells that he has decreased libido, that's a big giveaway that you should look for prolactin levels. Okay, that's very important to understand. And then thyroid levels are also important. If you have seen that your hypothyroidism and hypothyroidism, they also contribute to sperm morphology, mortality, and motility, and all these things. So thyroid and prolactin levels are also important. Let's not neglect them. I think that about sums it all, Monica, madam. We covered a lot of points. So
we are over 3 hours now, nearly 3.5 hours. So everyone has done a fantastic job. And yesterday, Purnima, myself, and Manisha, we were thinking we'll have 10 panelists, but there were 4 visits down. But still, we did brilliantly. And Dr. Venugopal, you were terrific. And
no,
Dr.
our panelists were superb, madam. I think they deserve big round of applause. The panelists. Because unless you have interactive panelists, the panel discussion becomes very boring, actually. So I think you should
मोनिका तुम्हें स्टैंडर्ड बना देना चाहिए वेणुगोपाल को. इससे अच्छा मॉडरेटर नहीं हो सकता था.
And no tension to the panelists. No stress was given. It was cool.
They were asking me for slides, Monica, madam. I said, there's no need of slides. Spontaneity is the need. Then only we learn, It's not like just reading out some guideline and this thing. When we are spontaneous, we learn better. So
and Dr. Udyan, when I called Dr. Udyan, he said, Monica, he was very double-minded about saying yes to me. But I was very persuasive. And ultimately, he said, okay, I'll join. And he has done such a great job. And
thank you so much.
Everyone has enjoyed.
Thank you so much, Dr. Monica, for having invited me.
Please show that slide CCQ, where to use that CCQ, because in practice, I'm not using it, sir. Only letrozole.
I had it in another presentation. Monica, ma'am, if we could have another, that's a separate sort of approach to that particular presentation.
No, we'll have another session. Yeah, if you could put those slides in the perfection group for the benefit of our panelists.
I will put it. Definitely, I'll put it. Definitely.
So don't forget to put it after
100%.
So I have one question. So like we were talking about erectile dysfunction, and we talked about that the psychogenic factors are the predominant ones. And currently I have one patient, as you gave an example of hymenectomy and all. That couple is married for 10 years. Yes. So the first time that male only came, for discussing his problem. Then next time I asked him to get his wife. He got the wife, and when I was doing her scan, she started weeping, and she said that, okay, he has shown me to X many people, and every time I get things, and there has been 10 years of marriage, but the only problem is in him. He's unable to do the coitus. And so when this was not told to me even by the male. So then I spoke to him separately, and I asked him about so basically what I found out was that when he gave the semen sample also, everything was possible. Only that libido was missing. Now, the thing is, now for me, how to convince that male, what all can I do from my end, to counsel this particular male? Because he has an age gap also.
Then why not IUIs?
Yeah.
No, I am doing IUI only this cycle.
No,
psychologically, because I want to help the couple as a marriage. Not just getting baby.
What I do is, I tell the patients, we'll de-link 2 things. Fertility one side, and sexual dysfunction on another side. That's very important. And then you have to take both these side by side. And then say that for the fertility part to succeed, it's very important that you take active participation in getting the sexual part of it also right. Because getting the sexual dysfunction right is important not only for the physical well-being, but for the emotional well-being, and it improves your chance of conceiving and becoming pregnant also. You have to coach, cajole, and do whatever things you have in your things. And then, sometimes they really respond well. And another magic that works is sometimes, as soon as the wife becomes pregnant, somehow by magic, the sexual dysfunction also sometimes gets relieved. It's not a solution you offer, but it's one of the carrots you offer. That's what I feel, they have to be dealt with.
Access catalyst there, yeah.
So that's what, as you said, counsel the wife, like ma'am said. So I spoke to her separately, and I said, you have to decide, because she was like, I want to leave him. He was not happy in the marriage.
Akriti, you brought out a very important point, and that is that this remains so much hidden under the carpet. Many a times you have to just talk to the lady alone, and then, she's the one who comes out with all these things. Sometimes it's just during the scan that you come out with all these things. It's very important, to
And
get
it
this
is a
out.
very good social observation because I've been practicing now last so many years in fertility, more than 2 decades. What I feel is in azoospermia and not conceiving, the couples carry on their married life for a long time because they adjust to that pattern of life, a childless but happy life. But sexual dysfunction, the marriage doesn't continue beyond a year also. Because, then it is a major, barrier between the couple. And to break it, besides the gynecologist, the gentle andrologist, and that counseling part is missing in India. We
No,
don't have
I
a
think,
third part.
madam, we
Yeah.
hesitate to ask difficult questions. We hesitate to ask sexual orientation. This is very important. We had so many cases where, you talk to the male alone and then, he'll have a homosexual orientation. These things. We don't discuss these things. We got to sit with the males, sit with the females, talk to them about all these things. That's the point, that need to be brought out. Otherwise, your search for a solution will go on endlessly, and just add to their woes and unhappiness. And then you said one point, madam, that they don't live together for more than a year. That is in some cases, but in some cases, it's very, 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 very sad to see 14 years of marriage, not even had intercourse even once. And then, once a lady told me, doctor, you try and get a dog in your house. After 2 months, you become attached to the dog also. The psychology that these people have, that that you stay with somebody after you just get attached to that person, that however whatever the things are, some couples live like that for years and years together.
Some do, but nowadays the youngsters, they are very
I
impatient
agree.
with
The
it.
reverse is also true.
If it doesn't work
Yeah.
out, it doesn't work out. So that ways I feel a live-in relationship should be encouraged because these young couples, at least they get to know each other, the compatibility and everything. They know about contraception. They know about barrier contraception. So parents have to be open-minded to the idea. And nowadays, like, yes, I met a friend who has got 2 sons. He said, from my prospective daughter-in-law, I'm going to take her AMH. I'm going to do her HIV, hepatitis B. Manika, no, her mother will do your husband's semen analysis. It's both ways. So nowadays people are so calculating so much. What is the girl's AMH? What is the husband's semen count? They have detectives and they will track.
The point
Yeah,
you
but
raised, I had friend,
sex-
a
yeah,
friend like this.
Indians have to be open-minded now. Like if sexual compatibility is the thing, then basically just having a failed marriage because of sexual dysfunction is worse than, just having a live-in relationship for a couple of months and years and then working out who's your best partner.
Very true. And I kept all these very basic things, ma'am, because we end up discussing about medicines, we end up discussing about antioxidants and all these things. But the male infertility part of it has got so much basics ingrained into it. The more we discuss this, the more we talk to the patients, a little bit more, I think we'll be doing a lot of justice to them. So that was the idea, people would have thought that our discussion was very plain and basic, but you take a lot of messages away from it, from all our participants, they gave inputs.
No, it was a very good discussion, Dr. Venugopal. You gave opportunity to everyone to give their inputs. You corrected where it was necessary, and you didn't you were basically not overpowering.
No.
So that's the way it should be. And I think we will have a part 2 of male infertility. We'll call Dr. Jindal again. We'll have some
We could.
good speaker again because he has a lot to give it to us.
Yeah.
I'm going to talk to Ashok Agrawal. Though Dr. Ashok Agrawal from US, he doesn't take lectures without payment. So it'll be very difficult to convince him. But if I can, sort of convince Dr. Ashok Agrawal to come in, maybe we can have another male infertility part 2 very soon. And so thank you, everyone. I think we have crossed 3.5 hours and everybody,
sir.
families must be waiting. Your dinner must be waiting. So let
Yeah.
us just wind up the program with a big, big thanks to all of you, to all our faculty, all wonderful panelists. Shashi Bala was there even in the dry run yesterday. And
Ma'am, thank you so much for this opportunity. I'm really honored, and you don't have idea how
all of us
happy
are
and
honored.
enthusiastic
See,
I
all
am.
of us are honored, and we must thank Intaz and Dr. Vishal over there. A big
Thank
clap to Dr. Vishal. He is our Rahul Dravid from the studio. He's always there, and he's like, Purnima, myself, and Manisha forever after his life. but he is, tolerating all three of us. And thank you so much, Vishal. And
Thank
I
you.
think we just have a thank you slide and we'll give you a teaser for the next
Sir,
perfection.
sir, allow me to share my screen.
Yeah, Manisha has prepared a very nice Marvel Studio-like teaser.
I will request
Thank you,
Venugopal sir
ma'am.
to allow screen sharing. So
Sure,
stop.
sure. So can you stop your share, Venu?
We wanted to have a musical ending.
So girls are always coming up with bright ideas, and they keep me on my toes.
You keep us on toes, ma'am.
Okay, so this is the topic for next perfection series. Please stay tuned in 12th of March. It's a Tuesday and it's Fertility Preservation Day. We talk everything about fertility preservation. We have some star speakers, Dr. Nandita, who recently presented a paper on fertility preservation in FIGO. I was part of her writing team, so I know it. Dr. Madhuri Patil, who is authority on any subject in ART under the sun. And third is Dr. Suma from Sikandrabad, who won the Jaideep Malhotra Yuva Orator Award. And the paper she won the award with was on fertility preservation. So I met her in this place, Jaipur, in the recently concluded Genesis by INTAS, and I just pulled her in. I said, you must speak. And today, Dr. Asha Bakshi also told me that, Monica, I have a fantastic work on fertility preservation in adolescents. She is a fourth speaker. Plus, we have a fantastic panel. And who's our moderator, Purnima?
Dr. Gopinath, sir.
Dr. PM Gopinath
Yes.
is our moderator. So you can imagine, you learn everything about fertility preservation. So please stay tuned in to Perfection 12 on 12th of March. Thank you so much and have a wonderful evening and a great good night.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you, Dr. Monica. Thank you, Dr. Venugopal.
Thank you, sir.
Thank you so much.